Everybody. Welcome to No1doctor channel. Today video is about acquired heart disease, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about acquired heart disease. Aortic stenosis produces angina and exertional syncope episodes. There is a harsh mid-systolic heart murmur best heard at the right second intercostal space and along the left sternal border. Start workup with echocardiogram. Surgical valvular replacement is indicated if there is a gradient of more than 50 mm Hg, or at the first indication of congestive heart failure, angina, or syncope. Chronic aortic insufficiency produces wide pulse pressure and a blowing, high-pitched, diastolic heart murmur best heard at the second intercostal space and along the left lower sternal border, with the patient in full expiration. These patients are often followed with medical therapy for many years but should undergo valvular replacement at the first evidence on echocardiogram of beginning left ventricular dilatation. Acute aortic insufficiency because of endocarditis is seen in young drug addicts who suddenly develop congestive heart failure and a new, loud diastolic murmur at the right second intercostal space. Emergency valve replacement and long-term antibiotics are needed. Patients with a prosthetic valve need antibiotic prophylaxis for subacute bacterial endocarditis. Mitral stenosis is caused by rheumatic fever many years before presentation. It produces dyspnea non-exertion, orthopnea, paroxysmal nocturnal dyspnea, cough, and hemoptysis. There is a low-pitched, rumbling diastolic apical heart murmur. As it progresses, patients become thin and cachectic and develop atrial fibrillation. Workup starts with echocardiogram. As symptoms become more disabling, mitral valve repair becomes necessary with a surgical commissurotomy or a balloon valvuloplasty. Mitral regurgitation is most commonly caused by valvular prolapse. Patients develop exertional dyspnea, orthopnea, and atrial fibrillation. There is an apical, high-pitched, holosystolic heart murmur that radiates to the axilla and back. Workup and surgical indications are as above, with repair of the valvuloplasty preferred over prosthetic replacement. Coronary disease can happen to anybody including women, but the typical patient is a middle-aged sedentary man with a family history, a history of smoking, type 2 diabetes, and hypercholesterolemia. Progressive, unstable, disabling angina is the main reason to do cardiac catheterization and evaluate as a potential candidate for revascularization. Intervention is indicated if one or more vessels have 70 or greater stenosis and there is a good distal vessel. Preferably, the patient should still have good ventricular function. You cannot resuscitate dead myocardium. The general rule is the simpler the problem, the more it is amenable to angioplasty and stent, whereas more complex situations do better with surgery. Single vessel disease that is not the left main or the anterior descending is perfect for angioplasty and stent. Triple vessel disease makes multiple coronary bypass using the internal mammary for the most important vessel the best choice. Newer hybrid operating rooms that combine the facilities for heart surgery with the radiological equipment to do angioplasty increase flexibility to tailor the therapy for each specific patient. For example, the surgeons might hook up the internal mammary to the anterior descending, and then the interventional cardiologist might do angioplasty and stents on the other, less critical vessels. Post-op care of heart surgery patients often requires that cardiac output be optimized. If cardiac output is considerably under normal 5 liters min, or a cardiac index of 3, the pulmonary wedge pressure or left atrial pressure, or left end diastolic pressure should be measured. Low numbers 0 to 3 suggest the need for more fluids. High numbers 20 or above suggest ventricular failure. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Atif Ahmed.
Hello everybody. Welcome to No1doctor channel. Today video is about acute cholecystitis, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about acute cholecystitis. Definition: acute cholecystitis is an acute inflammation of gallbladder due to obstruction of neck of gallbladder or cystic duct stone. Another rare form of acute cholecystitis which occurs in absence of stone is called acalculous cholecystitis. Pathogenesis: direct pressure of calculus on the mucosa results in ischemia, necrosis, and ulceration with swelling, edema and impairment of venous return. This process increases and extends the extent of inflammation and favors bacterial multiplication. The end result may be pericholecystic abscess, fistula formation between gallbladder and bowel, gallbladder empyema or mucocele. Rarely, perforation of gallbladder and bile peritonitis. Commonly involved bacterial species in acute cholecystitis include E. coli, Klebsiella species, Streptococci species, Enterobacter species and Clostridial species. Clinical features. History of chronic cholecystitis or cholelithiasis. Women more affected than men. Moderate to severe right upper quadrant and epigastric pain which may radiate to the back. Fever and vomiting. Physical examination. Right upper quadrant tenderness usually with rebound tenderness. Gallbladder or inflammatory mass due to omentum wrapped around the GB may be palpable. Murphy's sign may be positive, sudden arrest of inspiration due to tenderness of inflamed gallbladder which is palpated during deep inspiration. Differential diagnosis: perforated or penetrated peptic ulcer disease, biliary colic, pneumonia, pancreatitis, hepatitis, pleurisy, appendicitis, myocardial ischemia or infarction. Investigation: WBC, leukocytosis, plain chest or abdominal X-ray, to check for pneumonia or radio-opaque stone. Ultrasound, detects calculi, gallbladder wall thickening and pericholecystic fluid. Treatment: 1. Conservative: admit the patient. Keep the patient NPO. Start on IV fluid. Insert NGT analgesics. Antibiotics to cover common causative bacteria, usually ampicillin and gentamicin are used. Follow the response to medical treatment with clinical improvement, fever, abdominal findings and WBC count reduction. Appoint the patient to undergo cholecystectomy after 6 weeks. 2. Surgical treatment. Cholecystectomy. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Atif Ahmed.
Hello everybody. Welcome to No1doctor channel. Today video is about amoebic liver abscess, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. share and be shared. Today we will talk about amoebic liver abscess. Amoebic liver abscess is a complication of amoebic dysentery. Incidence. The disease occurs approximately in 3 of patients with intestinal amoebiasis. It is more common in middle-aged male MF 9:1. Etiology. Entamoeba histolytica intestinal protozoal parasite. Pathology and pathogenesis. Amoeba reaches the liver by way of the portal vein from the focus of ulceration in the bowel wall. Hepatic lesion usually occurs in the right lobe and has the following characters: is large, single abscess. Contains characteristic liquid material which is reddish-brown anchovy paste fluid. Has thin wall with little or no fibrosis. Clinical manifestation. History. Chief complaints are fever, chills, right upper quadrant pain which may radiate to right shoulder area. There could also be a history of cough, pleuritic chest pain or dyspnea. Painful epigastric swelling if left lobe is involved. History of antecedent diarrhea. Weight loss. Physical examination. Physical examination can reveal the following findings. Tender hepatomegaly, almost constant feature. Tenderness over lower intercostal spaces with or without swelling and skin edema. Abnormal finding over the base of the lung. Investigations. Stool examination, cysts or trophozoites of entamoeba histolytica. WBC, leukocytosis. Hemoglobin, anemia in prolonged illness. Chest X-ray. Elevated right diaphragm, right side pleural effusion, obliteration of costophrenic or cardiophrenic angle. Ultrasound, localizes the abscess. Aspiration, anchovy paste aspirate is considered pathognomonic. Amoebic trophozoite can be seen from the aspirated fluid. Complications. 1. Secondary infection. The most common complication is pyogenic abscess. 2. Rupture. Direction of rupture can be into pleural cavity, lung, pericardium or peritoneum. 3. Shock due to rupture. Treatment. Can be medical or surgical. 1. Medical. Main modality of treatment. Oral metronidazole 750 mg TID for 10 days is effective in more than 90. Analgesics. Paracetamol rehydration and nutritional support. Correct anemia. 2. Surgical drainage. When there are complications like rupture or sign of imminent rupture. When there is no response to medical treatment within 48 to 72 hours. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Atef Ahmed.
Hello everybody. Welcome to No1doctor channel. Today video is about anorectal disease, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about anorectal disease. In all anorectal disease, cancer should be ruled out by proper physical exam, including proctosigmoidoscopic exam, even though the clinical presentation may suggest a specific benign process. Hemorrhoids typically bleed when they are internal, can be treated with rubber band ligation, or hurt when they are external, may need surgery if conservative treatment fails. Internal hemorrhoids can become painful and produce itching if they are prolapsed. Anal fissure happens to young women. They have exquisite pain with defecation and blood streaks covering the stools. The fear of pain is so intense that they avoid bowel movements and get constipated and sometimes refuse proper physical examination of the area. Exam may need to be done under anesthesia. The fissure is usually posterior, in the midline. A tight sphincter is believed to cause and perpetuate the problem, thus therapy is directed at relaxing it. Stool softeners, topical nitroglycerin, local injection of botulinum toxin, forceful dilatation, or lateral internal sphincterotomy. Calcium channel blockers such as diltiazem ointment 2T topically for 6 weeks have had an 80-90 success rate, as compared to only 50 success for botulinum toxin. Crohn's disease often affects the anal area. It starts with a fissure, fistula, or small ulceration, but the diagnosis should be suspected when the area fails to heal and gets worse after surgical interventions. The anal area typically heals very well because it has excellent blood supply. Failure to do so means Crohn's disease. Surgery, in fact, should not be done in Crohn's disease of the anus. A fistula, if present, could be drained with sedums while medical therapy is underway. Remicade helps healing. Rectal abscess. Perirectal abscess is very common. Patient is febrile, with exquisite perirectal pain that does not let him sit down or have bowel movements. Physical exam shows all the classic findings of an abscess: rubor, dolor, calor, and tumor lateral to the anus, between the rectum and the ischial tuberosity. Incision and drainage are needed, and cancer should be ruled out by proper examination during the procedure. If patient is severely diabetic, horrible necrotizing soft tissue infection may follow. Watch him closely. Fistula and ano develops in some patients who have had an rectal abscess drained. Epithelial migration from the anal crypts where the abscess originated and from the perineal skin where the drainage was done form a permanent tract. Patient reports fecal soiling and occasional perineal discomfort. Physical exam shows opening or openings lateral to the anus, a cord-like tract may be felt, and discharge may be expressed. Rule out necrotic and draining tumor, and treats with fistulotomy. Squamous cell carcinoma of the anus is more common in HIV, and in homosexuals with receptive sexual practices. Fungating mass grows out of the anus. Metastatic inguinal nodes are often felt. Diagnose with biopsy. Treatment starts with chemoradiation protocol, followed by surgery if there is residual tumor. Currently the 5-week chemoradiation protocol has a 90 success rate, so surgery rarely is required. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Atif Ahmed wishes. Hello everybody. Welcome to No1doctor channel. Today video is about appendicitis, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about appendicitis. Appendicitis is an inflammation of the appendix that results from bacterial invasion, usually distal to an obstruction of the lumen. Appendicitis begins with obstruction of the narrow lumen by lymphoid hyperplasia, fecal material fecalith, foreign body seeds or worms etc. Following obstruction of the lumen, a continued secretion of mucus produces distension of the distal end. The distension results in ischemia of the wall with bacterial proliferation. Subsequently, a patchy necrosis, gangrene and perforation develop, resulting in peritonitis and sepsis and finally death. Symptoms: central abdominal colic which shifts to a pain in the right iliac fossa. Anorexia, nausea, episodes of vomiting and low-grade fever. High-grade fever usually indicates perforation and peritonitis. Signs: tenderness and localized rigidity in the right lower quadrant over MC Bernese point, 2 inches from the anterior superior iliac spine on a line drawn to the umbilicus. Rovsing's sign, pain in right lower quadrant on pressing in the left lower quadrant. Psoas sign, pain on extension of the right flexed hip. Obturator sign, pain on passive internal or external rotation of the flexed right hip. Right-sided tenderness on rectal examination. Diminished bowel sounds indicating peritonitis. Differential diagnosis. In children. Intussusceptions. Mesenteric adenitis. In female patient. Pelvic inflammatory disease. Right salpingitis. Ruptured ectopic pregnancy. Twisted ovarian cyst torsion, ruptured ovarian follicle. In general population. Acute cholecystitis. Perforated peptic ulcer disease. Renal or ureteric calculi. Urinary tract infection. Early small bowel obstruction. Volvulus gastroenteritis. Referred pain from the pleura. Basal pneumonia management. Resuscitation of the patient with fluids and other supportive treatment. Appropriate antibiotics combination for coverage of gram-positive, gram-negative and anaerobes. Correct all deficits. Dehydration. Surgery. Surgical removal of the appendix is the definitive treatment. N.B. Close follow-up of surgical patient is very important post-operatively to identify complications as early as possible and correct in time. Complications. Complications of acute appendicitis include perforation with local or generalized peritonitis, appendiceal mass and abscess formation. Delayed diagnosis and treatment may lead to complications and death. Management of appendicular mass. If appendicitis is not recognized and treated early, it may progress in one of two ways: 1. Perforation and peritonitis. 2. Organized appendiceal mass or progress to appendiceal abscess. The inflammatory process may become walled off in the right iliac fossa by omentum and loops of bowel to form a mass. The management of appendix masses conservatively with combined antibiotics for anaerobes, aerobes and gram-negative bacterial and fluids. The drug of choice is a combination of metronidazole and ceftriaxone if available. If this combination is not available, use ampicillin, chloramphenicol and gentamicin instead. Patient should be followed up, strictly monitoring the vital signs every 4 hours. The mass size and consistency 12 hourly. Patient's condition and laboratory every other day. If the mass settles on conservative management, the patient can be discharged and readmitted for interval appendectomy 6 weeks later. Otherwise, if there is any sign suggestive of progression to an abscess, increasing mass size, fluctuation, persistence of systemic signs, emergency laparotomy has to be done for drainage of the abscess and appendectomy if the appendix is easily found. If the appendix is embedded in the conglomerated mass, one should not struggle to deliver it for fear of damage to surrounding structures. Interval appendectomy after emergency drainage is preferred in this case. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Atif Ahmed.
Hello everybody. Welcome to No1doctor channel. Today video is about back pain, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about back pain. Lumbar disc herniation occurs almost exclusively at L4, L5 or L5S1. The peak age incidence is 45-46. Patients often describe several months of vague aching pain, the discogenic pain produced by pressure on the anterior spinal ligament before they have the sudden onset of the neurogenic pain precipitated by an event like attempting to lift a heavy object. The latter is extremely severe, like an electrical shock that shoots down the leg exiting on the side of the big toe in L4-L5, or the side of the little toe in L5-S1, and it is exacerbated by coughing, sneezing, or defecating if the pain is not exacerbated by those activities. The problem is not a herniated disc. Patients cannot ambulate, and they hold the affected leg flexed. Straight leg raising test gives excruciating pain. MRI confirms the diagnosis. Spontaneous resolution is the rule, as the body reabsorbs the extruded disc. This process used to be very inconvenient for the patient, requiring 3 weeks of strict bed rest. The advent of pain control specialists, who perform nerve blocks under radiological guidance, has made the recovery period much easier. Surgical intervention is needed if neurologic deficits are progressive muscle weakness, and emergency intervention is required if there is a cauda-equina syndrome. The cauda-equina syndrome, distended bladder, flaccid rectal sphincter, perineal saddle anesthesia is a surgical emergency requiring immediate decompression. Ankylosing spondylitis is seen in young men in their 30s or early 40s who complain of chronic back pain and morning stiffness. The pain is worse at rest, and improves with activity. Symptoms are progressive, and X-rays eventually show a bamboo spine. Anti-inflammatory agents and physical therapy are used. Many of these patients have the HLA-B27 antigen, which is also associated with uveitis and inflammatory bowel disease. Metastatic malignancy should be suspected in the elderly who have progressive back pain that is worse at night and unrelieved by rest or positional changes. Weight loss is often an additional finding. If advanced, X-rays will show the lesions in women, lytic breast cancer metastases at the pedicles in men, blastic metastases are from the prostate. At a higher cost, MRI is the best diagnostic too. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Atif Ahmed.
Hello everybody. Welcome to No1doctor channel. Today video is about benign prostatic hyperplasia, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about benign prostatic hyperplasia (BPH). Surgical anatomy. These are 3 zones in the prostate gland. Peripheral zone, mainly the posterior aspect of the gland. Central zone, the gland posterior to urethral lumen above the ejaculation duct. Periurethral zone, this part is on which most of benign enlargement of the prostate arises. Benign prostatic hyperplasia starts in the periurethral zone, and as it increases in size it compresses the outer peripheral zone. This zone finally becomes the false capsule. The gland is acted upon by testosterone, male hormone, incriminated to cause the enlargement. Clinical feature: acute urinary obstruction. Symptoms of prostatism: frequency, dysuria, urgency, dribbling, hesitancy, chronic retention, overflow incontinence, and renal insufficiency. Investigation and assessments: digital rectal examination, serum PSA prostatic specific antigen, ultrasonography and IVU, cystoscopy, transrectal ultrasonography. Management of BPH: if associated with bypass catheter and allow drainage, then prostatectomy. In cases only with symptoms of prostatism, other conservative measures can be tried. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Atif Ahmed. Hello everybody. Welcome to No1doctor channel. Today video is about brain tumors, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about brain tumors. Most intracranial tumors are metastatic, rather than primary, which is not surprising since the brain is one of the 4 favorite destinations of blood-borne malignant cells along with bone, liver, and lung. About half come from the lung. The next most common are breast and melanoma. The symptoms are those of a space-occupying lesion detailed in the next paragraph. A further clinical clue is that the patient has had one of those cancers. About half of primary brain tumors in the adult are gliomas. Meningiomas account for about 20. The most malignant intracranial tumor is glioblastoma multiforme, a type of glioma. Meningiomas are usually benign. The treatment of brain tumors is typically multimodal, including surgery, radiation, and chemotherapy for those cases where the blood-brain barrier has already been breached. Brain tumors may offer no clue as to location if they press on a silent area of the brain. The only history will be progressively increasing headache for several months, worse in the mornings, and eventually accompanied by signs of increased ICP, blurred vision, papilledema, projectile vomiting, and at the extreme of the spectrum, bradycardia and hypertension due to the Cushing reflex. Brain tumors can be visualized very well on CT scan, but MRI gives better detail and is the preferred study. While awaiting surgical removal, increased ICP is treated with high-dose steroids, i.e., dexamethasone, trade name Decadron. Clinical localization of brain tumors may be possible by virtue of specific neurologic deficits or symptom patterns. For example, the motor strip and speech centers are often affected in tumors that press on the lateral side of the brain, producing symptoms on the opposite side of the body. People speak with the same side of the brain that controls their dominant hand. Other classic clinical pictures include the following: tumors at the base of the frontal lobe produce inappropriate behavior, optic nerve atrophy on the side of the tumor, papilledema on the other side, and anosmia. Foster-Kennedy syndrome. Craniopharyngioma occurs in youngsters who are short for their age, and they show bitemporal hemianopsia and a calcified lesion above the cilia on CT scan. Prolactinomas produce amenorrhea and galactorrhea in young women. Diagnostic workup includes ruling out pregnancy test, ruling out hypothyroidism TSH, determination of prolactin level, and MRI of the cilia. Therapy with bromocriptine, or a similar drug, is used in most cases. Transnasal, transsphenoidal surgical removal is reserved for those who wish to get pregnant or those who fail to respond to bromocriptine. Acromegaly is recognized by the huge hands, feet, tongue, and jaws, and in the USMLE exam by the picture of a man showing both hands on either side of his face in the frontal view, and a long prominent jaw in the lateral view. Additionally, there is hypertension, diabetes, sweaty hands, headache, and a history of wedding bands or hats that no longer fit. Workup starts with determination of somatomidine C, and pituitary MRI. Surgical removal is preferred, transnasal or transsphenoidal, but radiation is an option. The somatic changes are irreversible. Pituitary apoplexy occurs when there is bleeding into a pituitary tumor, with subsequent destruction of the pituitary gland. The history may have clues to the long-standing presence of the pituitary tumor: headache, visual loss, endocrine problems, and the acute episode starts with a severe headache followed by signs of increased compression of nearby structures by the hematoma, deterioration of remaining vision, bilateral pallor of the optic nerves, and pituitary destruction, stupor, and hypotension. Steroid replacement is urgently needed, and eventually other hormones will need to be replaced. MRI or CT scan will show the extent of the problem. Tumors of the pineal gland produce loss of upper gaze and the physical finding known as sunset Hesperin syndrome. Brain tumors in children are usually in the posterior fossa. Medulloblastoma is the most common type. It arises in the cerebellum and gives the classic cerebellar symptoms, such as stumbling around and truncal ataxia. The second most common type is ependymoma. Some of those pivot on a pedicle, and affected children often assume the neatest position to open the flow of cerebrospinal fluid and relieve their headache. Brain abscess shows many of the same manifestations of brain tumors. It is a space-occupying lesion, but a much shorter timetable, a week or two. There is fever, and usually an obvious source of the infection nearby, like otitis media and mastoiditis. They have a very typical appearance on CT, thus the more expensive MRI is not needed. Actual resection is required. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atif Ahmed.
Hello everybody. Welcome to No1doctor channel. Today's video is about diseases of the breast, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about diseases of the breast. In all breast disease, cancer must be ruled out even if the presentation suggests benign disease. The only sure way to rule out cancer is to get tissue for the pathologist. Age correlates best with the odds for cancer, virtually unknown in the teens, rare in young women, quite possible by middle age, and very likely in the elderly. The much quoted statement 1 of every 8 women in the United States will develop breast cancer is true only for those who have reached the age of 85. Women with family history are at risk from an earlier age. When breast cancer arises in young women, it tends to be very aggressive. Mammography is not a substitute for tissue diagnosis but an adjunct to physical examination. Breast masses that may be missed by palpation may be seen in X-rays, and vice versa. As a regular screening exam, mammography should be started at age 40 earlier if there is family history. Mammograms are not done before age 20. Breast is too dense or during lactation all you see is milk, but they can be done if needed during pregnancy. Mammographically or sonographically guided multiple core biopsies have become the most convenient, effective, and inexpensive way to biopsy breast masses, whether they are palpable or are discovered by screening mammogram. Women who inherit the BRCA gene need early and frequent screening, but it should be done with MRIs rather than mammograms, which are carcinogenic if repeated frequently. Furthermore, past the age of 30 they should consider prophylactic bilateral mastectomies if they have the BRCA2 mutation, and that plus oophorectomies if they have the BRCA1 mutation. Fibroadenomas are seen in young women late teens, early 20s as a firm, rubbery mass that moves easily with palpation. Either fine needle aspiration FNA or sonogram is sufficient to establish diagnosis. Removal is optional. Most women want them out, and we are happy to oblige. Cystosarcoma phalloides is seen in the late 20s. They grow over many years, becoming very large, replacing and distorting the entire breast, yet not invading or becoming fixed. Most are benign, but they have potential to become outright malignant sarcomas. Core or incisional biopsy is needed. FNA is not sufficient, and removal is mandatory. Mammary dysplasia fibrocystic disease, cystic mastitis is seen in the 30s and 40s, goes away with menopause, with bilateral tenderness related to menstrual cycle worse in the last 2 weeks and multiple lumps that seem to come and go. They are cysts also following the menstrual cycle. If there is no dominant or persistent mass, mammogram is all that is needed. But if there is a persistent mass, presumably a cyst but potentially a tumor, further steps are required. Aspiration is done, not FNA, but aspiration with a bigger needle and syringe. If clear fluid is obtained and the mass goes away, that's it. If the mass persists or recurs after aspiration, formal biopsy is required. If bloody fluid is aspirated, it should be sent for cytology. Intraductal papilloma is seen in young women 20s to 40s with bloody nipple discharge. Mammogram is needed to identify other potential lesions, but it will not show the papilloma. They are tiny. Galactogram may be diagnostic and guides surgical resection. Breast abscess is seen only in lactating women. What appears to be a breast abscess at other times is cancer until proven otherwise. Incision and drainage is needed, but biopsy of the abscess wall should be part of the procedure. Breast cancer should be suspected in any woman with a palpable breast mass, and the index of suspicion goes up with the patient's age. Other strong indicators of cancer include ill-defined fixed mass, retraction of overlying skin, orange peel skin, recent retraction of the nipple, eczymatoid lesions of the areola, reddish orange peel skin over the mass, inflammatory cancer, and palpable axillary nodes. A history of trauma does not rule out cancer. Breast cancer during pregnancy is diagnosed exactly as if pregnancy did not exist and is treated the same way except for no radiotherapy or hormonal manipulations at any time during the pregnancy, and no chemotherapy during the first trimester. Termination of the pregnancy is not necessary. The radiological appearance of breast cancer is an irregular, speculated mass with asymmetric density, architectural distortion, or fine microcalcifications that were not there in the previous mammogram. Treatment of resectable breast cancer starts with either of two operations. Small lesions, located far away from the nipple and areola of a large breast, are removed within only a segment of the mammary gland. The operation is called lumpectomy, or segmental resection, and it must be followed by radiotherapy. Large tumors lying right under the nipple and areola, and occupying most of the small breast, require a simple total mastectomy and do not need subsequent radiation. If lymph nodes are not palpable in the axilla, either operation must include a sentinel node biopsy. If large lymph nodes are palpable in the axilla, they are resected. Infiltrating ductal carcinoma is the standard form of breast cancer. Inflammatory cancer is the only variant with much worse prognosis and the need for pre-op chemotherapy. Other variants, lobular, medullary, mucinous, have slightly better prognosis and are treated the same way as the standard infiltrating ductal. Lobular has higher incidence of bilaterality, but not high enough to justify bilateral mastectomy. Ductal carcinoma in situ cannot metastasize, thus no axillary sampling is needed, but has very high incidence of recurrence if only local excision is done. Total simple mastectomy is recommended for multicentric lesions throughout the breast because of the possibility of missing an invasive focus in multicentric disease. Many practitioners add a sentinel node biopsy in those. Lumpectomy followed by radiation is used if the lesion or lesions is confined to 1/4 of the breast. Inoperable cancer of the breast is treated with chemotherapy, may also add radiation, and sometimes it is rendered operable. Inoperability is based on local extent, not metastases. Adjuvant systemic therapy should follow surgery in virtually all patients, particularly if axillary nodes are positive. Chemotherapy is used in most cases, and hormonal therapy is added if the tumor is receptor positive. Premenopausal women receive tamoxifen, and postmenopausal women receive anastrozole. Frail, old women with tumors that are not too aggressive may be offered hormonal therapy alone. Women who are positive for HER2 receptors should be given trastuzumab Herceptin along with chemotherapy. It should not be given alone. Trastuzumab is currently the most powerful drug we have for systemic breast cancer. Persistent headache or back pain with areas of localized tenderness in women who recently had breast cancer suggests metastasis. MRIs are diagnostic. Brain metastases can be radiated or resected. The vertebral pedicles are the favorite location in the spine. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Ataf. Best wishes, Dr.
Hello everybody. Welcome to No1doctor channel. Today video is about carcinoid syndrome, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about carcinoid syndrome. Occurs when a rare cancerous tumor called a carcinoid tumor secretes certain chemicals into your bloodstream, causing a variety of signs and symptoms. A carcinoid tumor, which is a type of neuroendocrine tumor, occurs most often in the gastrointestinal tract or the lungs. Carcinoid syndrome typically occurs in people who have carcinoid tumors that are advanced. Treatment for carcinoid syndrome usually involves treating the cancer. However, because most carcinoid tumors don't cause carcinoid syndrome until they're advanced, a cure may not be possible. Medications may be recommended to relieve your carcinoid syndrome symptoms and make you more comfortable. Symptoms. The signs and symptoms of carcinoid syndrome depend on which chemicals the carcinoid tumor secretes into your bloodstream. The most common signs and symptoms include skin flushing. The skin on your face and upper chest feels hot and changes color ranging from pink to purple. Flushing episodes may last from a few minutes to a few hours or longer. Flushing may happen for no obvious reason, though sometimes it can be triggered by stress, exercise or drinking alcohol. Facial skin lesions. Purplish areas of spider-like veins may appear on your nose and upper lip. Diarrhea. Frequent, watery stools sometimes accompanied by abdominal cramps may occur in people who have carcinoid syndrome. Difficulty breathing. Asthma-like signs and symptoms, such as wheezing and shortness of breath, may occur at the same time you experience skin flushing. Rapid heartbeat. Periods of a fast heart rate could be a sign of carcinoid syndrome. Causes. Carcinoid syndrome is caused by a carcinoid tumor that secretes serotonin or other chemicals into your bloodstream. Carcinoid tumors occur most often in the gastrointestinal tract, including your stomach, small intestine, appendix, colon and rectum. Only a small percentage of carcinoid tumors secrete the chemicals that cause carcinoid syndrome. When these tumors do secrete the chemicals, the liver normally neutralizes the chemicals before they have a chance to travel through your body and cause symptoms. However, when an advanced tumor spreads metastasizes to the liver itself, it may secrete chemicals that aren't neutralized before reaching the bloodstream. Most people who experience carcinoid syndrome have an advanced cancer that has spread to the liver. Some carcinoid tumors don't have to be advanced to cause carcinoid syndrome. For instance, carcinoid lung tumors that secrete chemicals into the blood do so far they're upstream from the liver, which then cannot process and eliminate the chemicals. Carcinoid tumors in the intestine, on the other hand, secrete the chemicals into blood that must first pass through the liver before reaching the rest of the body. The liver usually neutralizes the chemicals before they can affect the rest of the body. What causes carcinoid tumors is unclear. Complications. Having carcinoid syndrome can cause the following complications. Carcinoid heart disease. Some people with carcinoid syndrome develop carcinoid heart disease. Carcinoid syndrome causes problems with the heart valves, making it difficult for them to function properly. As a result, the heart valves may leak. Signs and symptoms of carcinoid heart disease include fatigue and shortness of breath. Carcinoid heart disease can eventually lead to heart failure. Surgical repair of damaged heart valves may be an option. Carcinoid crisis. Carcinoid crisis causes a severe episode of flushing, low blood pressure, confusion and breathing difficulty. Carcinoid crisis can occur in people with carcinoid tumors when they are exposed to certain triggers, including anesthetic used during surgery. Carcinoid crisis can be fatal. Your doctor may give you medications before surgery to reduce the risk of carcinoid crisis. Diagnosis. Your doctor will assess your signs and symptoms to rule out other causes of skin flushing and diarrhea. If no other causes are found, your doctor may suspect carcinoid syndrome. To confirm a diagnosis, your doctor may recommend further tests, including urine test. Your urine may contain a substance made when your body breaks down serotonin. An excess amount of this substance could indicate that your body is processing extra serotonin, the chemical most commonly excreted by carcinoid tumors. Blood test. Your blood may contain high levels of certain substances that are released by some carcinoid tumors. Imaging tests. Imaging tests may be used to locate the primary carcinoid tumor and determine whether it has spread. Your doctor may start with a CT scan of your abdomen, because most carcinoid tumors are found in the gastrointestinal tract. Other scans, such as MRI or nuclear medicine scans, may be helpful in certain situations. A scope or camera to see inside your body. Your doctor may use a long, thin tube equipped with a lens or camera to examine areas inside your body. An endoscopy, which involves passing a scope down your throat, may help your doctor see inside your gastrointestinal tract. A bronchoscopy, which uses a scope passed down your throat and into your lungs, can help find lung carcinoid tumors. Passing a scope through your rectum colonoscopy can help diagnose rectal carcinoid tumors. Removing tissue for laboratory testing. A sample of tissue from the tumor biopsy may be collected to confirm your diagnosis. What type of biopsy you'll undergo depends on where your tumor is located. Treatment. Treating carcinoid syndrome involves treating your cancer and may also involve using medications to control your specific signs and symptoms. Treatments may include surgery. Surgery to remove your cancer or most of your cancer may be an option. Medications to block cancer cells from secreting chemicals. Injections of the medications octreotide sandostatin and lanreotide somatolene depot may reduce the signs and symptoms of carcinoid syndrome, including skin flushing and diarrhea. A drug called telotristat zermelo can be combined with these drugs to control diarrhea caused by carcinoid syndrome. Drugs that deliver radiation directly to the cancer cells. Peptide receptor radionuclide therapy (PRRT) combines a drug that seeks out cancer cells with a radioactive substance that kills them. In PRRT for carcinoid tumors, the drug is injected into your body, where it travels to the cancer cells, binds to the cells and delivers the radiation directly to them. This therapy is used in people who have advanced cancer that hasn't responded to other treatments. Stopping blood supply to liver tumors. In a procedure called hepatic artery embolization, a doctor inserts a catheter through a needle near your groin and threads it up to the main artery that carries blood to your liver hepatic artery. The doctor injects particles designed to clog the hepatic artery, cutting off the blood supply to cancer cells that have spread to the liver. The healthy liver cells survive by relying on blood from other blood vessels, killing cancer cells in the liver with heat or cold. Radiofrequency ablation delivers heat through a needle to the cancer cells in the liver, causing the cells to die. Cryotherapy is similar, but it works by freezing the tumor. Chemotherapy. Chemotherapy uses strong drugs to kill cancer cells. Chemotherapy drugs can be given through a vein intravenously or in pill form, or both methods can be used. Lifestyle and home remedies. Talk to your doctor about self-care measures that may improve your signs and symptoms. Self-care measures can't replace treatment, but they may complement it. Ask your doctor if you should avoid things that cause skin flushing. Certain substances or situations, such as alcohol or large meals, can trigger flushing. Keep track of what causes your flushing, and try to avoid those triggers. Consider taking a multivitamin. Chronic diarrhea makes it difficult for your body to process the vitamins and nutrients in the food you eat. Ask your doctor whether taking a multivitamin may be a good idea for you. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Atif Ahmed wishes.
Hello everybody. Welcome to No1doctor channel. Today video is about care of the terminally ill patient, which is part of our playlist called Short Medical Notes. in which we will have short videos about important topic in medicine, but please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about care of the terminally ill patient. The dying phase is an important stage in a patient's illness and is often the stage which most affects the family and carers. A holistic approach is essential. Physical, psychological, social and spiritual needs must be addressed. Symptom control is a priority of palliative care. Many of the common symptoms are described above, but they also include terminal agitation, which is best treated with midazolam or haloperidol. Medications are often administered to a terminally ill patient by means of a syringe driver which allows a continuous infusion of medication to be given subcutaneously over a 24-hour period. Avoids the need for venous access and is suitable for the unconscious patient. Often contains a cocktail of medication, such as diamorphine, metoclopramide, hyoscine and midazolam. Multidisciplinary team approach is essential. Early involvement of specialist nurses and doctors. Consider continuing care in the hospice or at home with Macmillan support. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef.
Hello everybody. Welcome to No1doctor channel. Today video is about cataract, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about cataract causes. Opacification of the crystalline lens. May be congenital, for example maternal rubella, or acquired, for example trauma. Risk factors include increasing age, diabetes mellitus, steroid therapy, trauma, chronic uveitis. Symptoms: blurred vision, halos, glare. Signs: loss of red reflex, brownness in the lens under slit lamp examination, a white pupil if the cataract is advanced. Treatment: commonest operation in ophthalmology. Operation performed when vision affects activities of daily living for a given patient. Two main techniques are phacoemulsification. In phaco, the cataract is divided into portions by an ultrasound cutter and the diseased lens removed. Then an intraocular lens implant is placed within the eye, and occasionally extracapsular extraction. A small incision is used so stitches are not routinely necessary. The operation is usually done under local anesthetic and patients go home the same day. With extracapsular surgery, a large corneal incision is made and the lens is removed in one piece. The wound is stitched and a lens implant placed into the eye. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef Ahmed.
Hello everybody. Welcome to No1doctor channel. Today video is about congenital heart problems, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about congenital heart problems. When a child has expiratory wheezing, it suggests bronchoconstriction, i.e., asthma. Inspiratory wheezing is seen in tracheomalacia, where the tracheal rings collapse. But if the parents report that the child has some difficulty swallowing, as well as episodes of respiratory distress, with crowing respiration, stridor, and hyperextension of the neck, the problem is vascular ring, a congenital anomaly in which the trachea and esophagus are encircled by abnormal blood vessels. Extrinsic compression is demonstrated by barium swallow and bronchoscopy. Surgery divides the smaller of the two aortic arches. Morphologic cardiac anomalies, congenital or acquired, are best diagnosed with an echocardiogram. Left to right shunts share the presence of a murmur, overloading of the pulmonary circulation, and long-term damage to the pulmonary vasculature. The volume and consequences of the shunt are different at different locations, as noted below. Atrial septal defect has very minor, low-pressure, low-volume shunt. Patients typically grow into late infancy before it is recognized. A faint pulmonary flow, systolic murmur, and fixed split-second heart sound are characteristic. A history of frequent colds is elicited. Echocardiogram is diagnostic. Closure can be achieved surgically or by cardiac catheterization. Small, restrictive ventricular septal defects low in the muscular septum produce a heart murmur, but otherwise few symptoms. They are likely to close spontaneously within the first 2 or 3 years of life. Ventricular septal defects in the more typical location high in the membranous septum lead to trouble early on. Within the first few months there will be failure to thrive, a loud pansystolic murmur best heard at the left sternal border, and increased pulmonary vascular markings on chest X-ray. Echocardiogram and surgical closure. Patent ductus arteriosus becomes symptomatic in the first few days of life. There are abounding peripheral pulses and a continuous machinery-like heart murmur. Echocardiogram is diagnostic. In premature infants who have not gone into congestive heart failure, closure can be achieved with indomethacin. Those who do not close, those who are already in failure, or full-term babies need surgical division or radiological embolization with metal coils. Right to left shunts share the presence of a murmur, diminished vascular markings in the lung, and cyanosis. Although 5 are always described, all beginning with the letter T, 3 of them are rather rare and will not be reviewed. One of them, truncus arteriosus, is fascinating because it is cyanotic, but it kills by overloading the pulmonary circulation, like the non-cyanotic shunts do. The common ones follow. Tetralogy of Fallot, although crippling, often allows children to grow up into infancy. It is also the most common cyanotic anomaly, and thus any exam question in which a 5 or 6-year-old is cyanotic is bound to be tetralogy. The children are small for their age, have a bluish hue in the lips and tips of their fingers, clubbing, and spells of cyanosis relieved by squatting. There is a systolic ejection murmur in the left third intercostal space, a small heart, diminished pulmonary vascular markings on chest X-ray, and EKG signs of right ventricular hypertrophy. Echocardiogram is diagnostic, surgical repair is done. Transposition of the great vessels leads to severe trouble early on. The kids are kept alive by an atrial septal defect, ventricular septal defect, or patent ductus or a combination, but die very soon if not corrected. Suspect this diagnosis in a 1 or 2-day-old child with cyanosis who is in deep trouble, and ask for echocardiogram. The technical details of the surgical correction are mind-boggling, and you do not have to know them. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes.
Hello everybody. Welcome to No1doctor channel. Today video is about congenital urologic disease, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about congenital urologic disease. Posterior urethral valves are the most common reason for a newborn boy not to urinate during the first day of life. Meatal stenosis should also be looked for. Catheterization can be done to empty the bladder. The valves will not present an obstacle to the catheter. Voiding cystourethrogram is the diagnostic test, and endoscopic fulguration or resection will get rid of them. Hypospadias is easily noted on physical exam. The urethral opening is on the ventral side of the penis, somewhere between the tip and the base of the shaft. Circumcision should never be done on such a child, inasmuch as the skin of the prepuce will be needed for the plastic reconstruction that will eventually be done. Urinary tract infection in children should always lead to a urologic workup. The cause may be vesicoureteral reflux or some other congenital anomaly. Vesicoureteral reflux and infection produce burning on urination, frequency, low abdominal and perineal pain, flank pain, and fever and chills in a child. Start treatment of the infection with empiric antibiotics first, followed by culture-guided choice, and do voiding cystorethogram looking for the reflux. If found, long-term antibiotics are used until the child grows out of the problem. Low implantation of a ureter is usually asymptomatic in little boys but leads to a fascinating clinical presentation in little girls. The patient feels normally the need to void, and voids normally at appropriate intervals urine deposited into the bladder by the normal ureter, but she is also wet with urine all the time, urine that drips into the vagina from the low implanted ureter. Careful vaginoscopy should identify the ectopic ureter. IVPs are best avoided in children. Corrective surgery will follow. Uretropelvic junction UPJ obstruction can also produce a fascinating clinical presentation. The anomaly at the UPJ allows normal urinary output to flow without difficulty, but if a large diuresis occurs, the narrow area cannot handle it. Thus the classic presentation is an adolescent who goes on a beer drinking binge for the first time in his life and develops colicky flank pain. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atif Ahmed. Hello everybody. Welcome to No1doctor channel. Today video is about diabetic retinopathy, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine, but please do not forget to like and share our videos. Subscribe to our YouTube channel No1doctor and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about diabetic retinopathy, a long-standing diabetes, related to poor glycemic control. Basic problem is damage to the blood-retina barrier. This damage causes occlusion or leakage in the retinal circulation. Diabetic retinopathy consists of a spectrum of lesions. Classification of diabetic retinopathy. Background retinopathy. Hemorrhage. Leakage of blood into the retina. Blot, flame-shaped hemorrhages. Edema. Leakage of fluid transudate. Diabetic macular edema can occur even in background disease. Microaneurysms. Outpouchings of venous end of capillaries. Earliest sign of retinopathy, found in the central macula. Exudates. Leakage of lipid. Yellowish deposits, usually in the macula. Pre-proliferative retinopathy. Cotton wool spot. With blockage of fine retinal capillaries, exoplasmic flow is slowed, producing a feathery whitish area called a cotton wool spot. This represents a focal infarct. Vein abnormalities characterize an ischemic retina. Venous looping, beading and engorgement can be seen. Proliferative retinopathy. New vessel growth from the retina. New vessel growth from the optic disc. New vessel growth from the iris. Rubeosis. Advanced retinopathy. Scar tissue is laid down inside the eye. Tractional retinal detachment. Scar tissue associated with neovascular processes pulls on the retina. Retinal gliosis. Scarring. Vitreous hemorrhage. Symptoms and signs. Often asymptomatic, in later stages visual field loss. Investigations. Fundoscopy, retinal photography treatment. Medical, optimized glycemic control. Laser photocoagulation, can prevent progression from proliferative. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atif Ahmed.
Hello everybody. Welcome to No1doctor channel. Today video is about dysphagia. which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about dysphagia. Dysphagia, though an infrequent occurrence in clinical practice, is a very serious problem which makes the patient miserable, for he or she can't swallow food, fluids and even saliva. The causes differ according to the age of the patient, and the history may clearly suggest the diagnosis in some cases, like foreign body swallowing and corrosive ingestion, as in achalasia and cancer. One has to have a high index of suspicion and the help of special investigations. Most cases need a higher level of treatment, thus one should have a tentative diagnosis and convince the patient for early management at a hospital. Dysphagia is difficulty in swallowing classification, according to the site and cause 1. Oropharyngeal dysphagia. Causes local pain due to trauma, oral candida, tonsillitis, neuromuscular disorders, for example Parkinson's disease, mechanical causes, for example tumor 2. Esophageal dysphagia. Causes mechanical, for example foreign body, tumor, esophageal cancer, goiter dysmotility, like achalasia. Diagnosis. History. Dysphagia to solids or liquids. Progressive, static or intermittent. Duration. Associated pain, heartburn or weight loss. Examination, usually less revealing weight loss, emaciation, chest findings due to aspiration pneumonia. Investigations. Barium swallow radiography. Esophagoscopy. Endoscopic ultrasound. Manometry. Common surgical causes of dysphagia. Achalasia of the esophagus, cardiospasm. Etiology: motility disorder of the esophagus due to loss of ganglion cells in Auerbach's plexus. Pathophysiology: incomplete relaxation of lower esophageal sphincter. Stasis: esophageal dilatation, functional obstruction. Risk for cancer, in long-standing cases. Clinical feature: age 20-40 years, progressive dysphagia, insidious onset, regurgitation. Retrosternal discomfort, fetid flatulence and aspiration pneumonitis. Diagnosis: barium swallow, rat tail tapering, dilated esophagus, no gas in stomach. Esophagoscopy. Manometry. Treatment: disruption of the lower circular muscles, Heller's cardiomyotomy. Carcinoma of the esophagus. Epidemiology. 60 years, male, female, 5 of all cancers. Predisposing factors: ingestion of hot meal, smoking, alcohol intake. Pathology: microscopic, squamous cell carcinoma, adenocarcinoma. Macroscopically, annular stenosing, ulcer, fungating, cauliflower-like. Spread: direct, lymphatic and bloodstream to liver and bone. Clinical feature: dysphagia, regurgitation, anorexia, weight loss. Diagnosis: barium swallow, irregular, ragged pattern of mucosa with narrow lumen. Esophagoscopy and biopsy. Bronchoscopy to see bronchial involvement. Endoluminal ultrasonography. Ultrasonography, liver secondaries. Hemoglobin, plasma proteins, blood chemistry. Treatment: curative surgery. Radiotherapy. Palliative intubation with specially designed tubes. Radiotherapy. Foreign bodies, coins, pins, dentures. Diagnosis: radiography, neck and chest X-ray. Esophagoscopy. Treatment: removal by rigid esophagoscope. Esophagitis. Acute burns or scalds, infective spreading from the pharynx, for example candidiasis. Peptic. Chronic reflux due to hiatus hernia or previous surgery. Pathology: bleeding, granulation tissue replaces epithelium, upward displacement of the cardia. Clinical features: pain, heartburn, dysphagia, occult blood, secondary anemia. Diagnosis: barium swallow, esophagoscopy. Treatment: treat the cause, H2 blockers, omeprazole reflux, peptic surgery for sliding hernia. Caustic strictures. Treatment: acute inflammatory stage NPO, antibiotics and cortisone, stricture dilation, esophageal replacement. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Atif Ahmed. Best wishes.
Hello everybody. Welcome to No1doctor channel. Today video is about diseases of the endocrine system, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about diseases of the endocrine system. Most thyroid nodules are benign, but the few that are malignant must be diagnosed and treated. These can occur at any age, and the most worrisome item in the history would be prior exposure of the gland to radiation. As a rule, thyroid cancer does not affect thyroid function. Some practitioners start the workup with sonogram, which can exclude some lumps that are clearly not neoplastic. Otherwise the diagnosis is made by fine needle aspiration FNA, which in most cases indicates whether the node is benign. If so, follow-up, or has papillary, medullary, or anaplastic cancer. Follicular cancer is not easily diagnosed by FNA, and a lobectomy may be needed to determine if a follicular neoplasm is benign adenoma or malignant. Papillary cancer is very slow growing, and the extent of surgical resection is dictated by the size of the tumor or the presence of metastatic nodes. Follicular cancer has rudimentary function. It can take radioactive iodine if it does not have to compete with normal thyroid tissue. Thus, a total thyroidectomy is always done for follicular cancer, because doing so permits use of radioactive iodine in the future to identify and treat any potential metastasis. Medullary cancer comes from the C cells that make calcitonin useful for follow-up. It is aggressive, and radical surgery is justified. Workup for pheochromocytoma is indicated, as they often coexist. Men. Type 2. Anaplastic cancer is seen in old people. It grows like wildfire, and often all that can be done for the patient is a tracheostomy. Hyperthyroidism is treated with radioactive iodine in most cases. There is a very limited role for surgery on patients who have a hot adenoma. Hyperparathyroidism is most commonly found by serendipitous discovery of high serum calcium in blood tests rarely seen in the full florid disease of stones, bones, and abdominal groans. Repeat calcium determinations, look for low phosphorus, and rule out cancer with bone metastases. If findings persist, do parathyroid hormone PTH determination and interpret in light of serum calcium levels. Asymptomatic patients become symptomatic at a rate of 20 per year, thus elective intervention is justified. 90% have single adenoma. Removal is curative. Sestamier B scan helps locate the offending gland or glands, and intraoperative PTH assay confirms that they have been extirpated. In the few patients who have hyperplasia, transplantation of all the parathyroids to the forearm facilitates future titration to keep the disease under control. Cushing can be identified at a glance by looking at the picture of a lovely young woman next to a picture of a monster who is the same lady a couple of years later. The monster has a round, ruddy, hairy face, buffalo hump, supraclavicular fat pads, obese trunk with abdominal stria, and thin weak extremities. Osteoporosis, diabetes, hypertension, and mental instability are also present. Workup starts with an overnight low-dose dexamethasone suppression test. Suppression at low dosage rules out the disease. She is just a fat hairy lady. If there is no suppression, 24-hour urine-free cortisol is measured, and if elevated, we go to a high-dose suppression test. Suppression at a higher dose identifies pituitary microadenoma. No suppression at either dosage identifies adrenal adenoma or paraneoplastic syndrome. Do appropriate imaging studies: MRI for pituitary, CT scan for adrenal, and remove the offending adenoma. The Mayo Clinic advocates a different diagnostic algorithm, where the diagnosis of Cushing disease is established by 24-hour urinary collection for free cortisol levels. Patients with this disease have levels 3-4 times the normal and relies on measurement of corticotropin to differentiate pituitary adenomas from adrenal adenomas. Zollinger-Ellison gastrinoma shows up as virulent peptic ulcer disease, resistant to all usual therapy including eradication of Helicobacter pylori and more extensive than it should be, several ulcers rather than one, ulcers extending beyond first portion of the duodenum. Some patients also have watery diarrhea. Measure gastrin and do secretin test. If values are equivocal, locate the tumor with CT scan with contrast of the pancreas and nearby areas. Remove it. Omeprazole helps those with metastatic disease. Insulinoma produces CNS symptoms because of low blood sugar, always when the patient is fasting. Differential diagnosis is with reactive hypoglycemia. Attacks occur after eating and with self-administration of insulin. In the latter, the patients have reason to be familiar with insulin, some connection with the medical profession, or with a diabetic patient, and in plasma assays they have high insulin but low C-peptide. In insulinoma both are high. Do CT with contrast of pancreas to locate tumor, and remove it. Some medically sophisticated patients are using sulfonylureas to induce endogenous insulin secretion, and defeat the diagnostic value of C-peptide. Levels of those drugs need to be measured in the workup. Nocidioblastosis is a devastating hypersecretion of insulin in the newborn, requiring 95 pancreatectomy. Glucagonoma produces severe migratory necrolytic dermatitis, resistant to all forms of therapy, in a patient with mild diabetes, a touch of anemia, glossitis, and stomatitis. Glucagon assay is diagnostic, CT scan is used to locate the tumor, resection is curative. Somatostatin and streptozocin can help those with metastatic, inoperable disease. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Atif Ahmed. Best wishes. Dr. Hello everybody. Welcome to No1doctor channel. Today video is about otolaryngology ENT diseases, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about otolaryngology ENT diseases. Neck masses. Neck masses can be congenital, inflammatory, or neoplastic. Congenital masses are seen in young people, and typically have been present for years before they become symptomatic, get infected, and medical help is sought. The timetable of inflammatory masses is typically measured in days or weeks. After a few weeks an inflammatory mass has reached some kind of resolution, drained or resolved. The timetable of neoplastic masses is typically several months of relentless growth. Congenital. Thyroglossil duct cyst is located on the midline, at the level of the hyoid bone, and seems to be somehow connected to the tongue. Pulling at the tongue retracts the mass. They are typically 1 or 2 centimeters in diameter. Surgical removal includes the cyst, the middle segment of the hyoid bone, and the tract that leads to the base of the tongue. Some practitioners insist that the location of the normal thyroid should first be ascertained by radionuclide scan. Branchial cleft cysts occur along the anterior edge of the sternomastoid muscle, anywhere from in front of the tragus to the base of the neck. They are several centimeters in diameter and sometimes have a little opening and blind tract in the skin overlying them. Cystic hygroma is found at the base of the neck as a large, mushy, a well-defined mass that occupies the entire supraclavicular area and seems to extend deeper into the chest. Indeed, they often extend into the mediastinum, and therefore CT scan before attempted surgical removal is mandatory. Inflammatory versus neoplastic. Most recently discovered enlarged lymph nodes are benign, and therefore an expensive workup should not be undertaken right away. Complete history and physical should be followed by an appointment in 3 to 4 weeks. If the mass is still there, workup then follows. Persistent enlarged lymph nodes, a history of weeks or months could still be inflammatory, but neoplasia has to be ruled out. There are several patterns that are suggestive of specific diagnosis, as detailed below. Lymphoma is typically seen in young people. They often have multiple enlarged nodes in the neck and elsewhere and have been suffering from low-grade fever and night sweats. FNA can be done, but usually a node has to be removed for pathologic study to determine specific type. Chemotherapy is the usual treatment. Metastatic tumor to supraclavicular nodes invariably comes from below the clavicles and not from the head and neck. Lung or intra-abdominal tumors are the usual primaries. The node itself may be removed to help establish a tissue diagnosis. Squamous cell carcinoma of the mucosae of the head and neck is seen in old men who smoke and drink and have rotten teeth. Patients with AIDS are also prime candidates. Often the first manifestation is a metastatic node in the neck, typically to the jugular chain. The ideal diagnostic workup is a triple endoscopy or panendoscopy looking for the primary tumor or tumors. Biopsy of the primary or primaries establishes the diagnosis, and CT scan demonstrates the extent. FNA of the node may be done, but open biopsy of the neck mass should never be performed. An incision in the neck for that purpose will eventually interfere with the appropriate surgical approach for the tumor. Treatment involves resection, radical neck dissection, and very often radiotherapy and platinum-based chemotherapy. Other presentations of squamous cell carcinoma include persistent hoarseness, persistent painless ulcer in the floor of the mouth, and persistent unilateral lyric. Other tumors like acoustic nerve neuroma should be suspected in an adult who has sensory hearing loss in one ear, but not the other, and who does not engage in sport shooting that would subject one ear to more noise than the other. MRI is the best diagnostic modality. Facial nerve tumors produce gradual unilateral facial nerve paralysis affecting both the forehead and the lower face. Paralysis of sudden onset suggests Bell's palsy. Gadolinium-enhanced MRI is the best diagnostic study. Parotid tumors are visible and palpable in front of the ear or around the angle of the mandible. Most are pleomorphic adenomas, which are benign but have potential for malignant degeneration. They do not produce pain or facial nerve paralysis. A hard parotid mass that is painful or has produced paralysis is a parotid cancer. FNA of these tumors may be done, but open biopsy is absolutely contraindicated. A formal superficial parotidectomy or superficial and deep if the tumor is deep to the facial nerve is the appropriate way to excise and thereby biopsy parotid tumors, preventing recurrences and sparing the facial nerve. Enucleation alone leads to recurrence. In malignant tumors the nerve is sacrificed and a graft done. Pediatric ENT. Foreign bodies are the cause of unilateral ENT problems in toddlers. A 2-year-old with unilateral lyric, unilateral rhinorrhea, or unilateral wheezing has a little toy truck substitute for your favorite toy if you wish in his ear canal, up his nose, or into a bronchus. The appropriate endoscopy under anesthesia will allow extraction. ENT emergencies and miscellaneous. Ludwig angina is an abscess of the floor of the mouth, often the result of a bad tooth infection. The usual findings of an abscess are present, but the special issue here is the threat to the airway. Incision and drainage are done, but intubation and tracheostomy may also be needed. Bell's palsy produces sudden paralysis of the facial nerve for no apparent reason. Although not an emergency per se, current practice includes the use of antiviral medications, and as is the case for other situations in which antivirals are used, prompt and early administration is the key to their success. Steroids are also typically prescribed. Facial nerve injuries sustained in multiple trauma produce paralysis right away. Patients who have normal nerve function at the time of admission and later develop paralysis have swelling that will resolve spontaneously. Cavernous sinus thrombosis is heralded by the development of diplopia from paralysis of extrinsic eye muscles, along with facial pain and high fever, in a patient suffering from frontal or ethmoid sinusitis. This is a rare but very serious emergency 30 mortality that requires hospitalization. Diagnosis is best done with MRI. Treatment is based on early and aggressive 4 antibiotic administration, for a minimum of 3 or 4 weeks, with penicillinase-resistant penicillin plus a 3rd or 4th generation cephalosporin. While the cavernous sinus itself would not benefit from operative intervention, the responsible paranasal sinuses should be surgically drained. Epistaxis in children is typically from nose picking. The bleeding comes from the anterior septum, and phenylephrine spray and local pressure controls the problem. In an 18-year-old, the prime suspects are cocaine abuse with septoperforation or juvenile nasopharyngeal angiofibroma. Posterior packing may be needed for the former, and surgical resection is mandatory for the latter. The tumor is benign, but it eats away at nearby structures. In the elderly and hypertensive, nosebleeds can be copious and life-threatening. The blood pressure has to be controlled, and posterior packing is usually required. Sometimes surgical ligation of feeding vessels is the only way to control the problem. Dizziness may be caused by inner ear disease or cerebral disease. When the inner ear is the culprit, the patients describe the room spinning around them. When the problem is in the brain, the patient is unsteady but the room is perceived to be stable. In the first case, meclizine, promethazine, or diazepam may help. In the second case, neurologic workup is in order. Full-fledged Meniere's disease includes vertigo, tinnitus, and hearing loss. It is treated primarily with diuretics. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef Ahmed.
Hello everybody. Welcome to No1doctor channel. Today video is about facial nerve palsy, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about facial nerve palsy. Causes: Bell's palsy, acoustic neuromas, multiple sclerosis, infarcts, tumors, Lyme disease, sarcoidosis, Ramsay-Hunt syndrome, facial palsy due to herpes zoster affecting the geniculate ganglion. Symptoms and signs: facial weakness, upper motor neuron palsy, the frontalis and orbicularis oculi function are preserved, i.e. the patient can raise their eyebrows. Lower motor neuron palsy, this function is lost. Ramsay-Hunt syndrome, vesicular eruptions of herpes zoster. Acoustic neuromas, involvement of the 8th cranial nerve. Sarcoidosis, parotid gland enlargement. Tenderness. Investigations: Bell's palsy, Ramsay-Hunt syndrome. Lower motor neuron palsy do not require further investigation. Other conditions listed are described in their own relevant sections. Treatment: Medicall, steroids for Bell's palsy, acyclovir if any evidence of herpes zoster. Supportive, taping down eyelids overnight to prevent corneal drying. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef Ahmed. Hello everybody. Welcome to No1doctor channel. Today video is about facial nerve palsy, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine, but please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about facial nerve palsy. Causes: Bell's palsy, acoustic neuromas, multiple sclerosis, infarcts, tumors, Lyme disease, sarcoidosis. Ramsay-Hunt syndrome, facial palsy due to herpes zoster affecting the geniculate ganglion. Symptoms and signs: facial weakness. Upper motor neuron palsy, the frontalis and orbicularis oculi function are preserved, i.e. the patient can raise their eyebrows. Lower motor neuron palsy, this function is lost. Ramsay-Hunt syndrome, vesicular eruptions of herpes zoster. Acoustic neuromas, involvement of the 8th cranial nerve. Sarcoidosis, parotid gland enlargement. Tenderness. Investigations: Bell's palsy. Ramsay-Hunt syndrome. Lower motor neuron palsy do not require further investigation. Other conditions listed are described in their own relevant sections. Treatment: Medicall, steroids for Bell's palsy, acyclovir if any evidence of herpes zoster. Supportive, taping down eyelids overnight to prevent corneal drying. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef Ahmed.
Hello everybody, welcome to No1doctor channel. Today video is about foot pain, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine, but please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about foot pain. Plantar fasciitis is a very common but poorly understood problem affecting older, overweight patients who complain of disabling, sharp heel pain every time their foot strikes the ground. The pain is worse in the mornings. X-rays show a bony spur matching the location of the pain, and physical exam shows exquisite tenderness to palpation over the spur. Yet the bony spur is not the cause of the problem. Many asymptomatic people have similar spurs. Spontaneous resolution can be expected in 12-18 months, during which time symptomatic treatment is offered, and removal of the bony spur may help. Morton neuroma is an inflammation of the common digital nerve at the third interspace, between the third and fourth toes. The neuroma is palpable as a very tender spot there. The cause is typically the use of pointed, high-heeled shoes or pointed cowboy boots that force the toes to be bunched together. Conservative management includes analgesics and more sensible shoes, but, if needed, surgical excision can be done. Gout produces the typical swelling, redness, and exquisite pain of sudden onset at the first metatarsal phalangeal joint, in a middle-age obese man with high serum uric acid. Uric acid crystals are identified in fluid from the joint. Treatment for the acute attack is done with indomethacin and colchicine. Allopurinol and probenecid are used for chronic control. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef.
Hello everybody. Welcome to No1doctor channel. Today video is about gastric cancer, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine, but please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about gastric cancer. Epidemiology. Age 40-60 years. Sex male to female 3:1. More common in Far East Japan. Etiology. Premalignant conditions and risk factors: gastric polyp, pernicious anemia, post-gastrectomy stomach, gastritis, cigarette smoking and genetic makeup. Pathology. prepyloric region is the most common site. Microscopic adenocarcinoma. Spread. Direct, lymphatic, transperitoneal, bloodstream. Clinical features. New onset dyspepsia in patients above the age of 40 years. Anorexia and loss of weight. Anemia, tiredness, weakness, pallor. Persistent pain with no response to medical treatment. Gastric distension. Dysphagia or fullness, belching and vomiting. Other signs. Virchow's nodes on the neck, Krukenberg tumor in the pelvis, etc. Abdominal mass. Ascites. Investigations. Gastroscopy and biopsy. Hemoglobin. Barium meal shows filling defect. Laparotomy diagnostic. Treatment. Gastrectomy when possible. Palliative bypass surgery. Prognosis. Overall 5 years survival is about 10-20. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Atif Ahmed.
Hello everybody. Welcome to No1doctor channel. Today video is about gallstone disease, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine, but please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about gallstone disease cholelithiasis. Gallstone disease is the most common pathology of the biliary tract. Classification. 1. Cholesterol stone 6, usually solitary. 2. Mixed stone 90. Cholesterol is the major component with others like calcium bilirubinate. These type of stones are multiple, faceted and usually associated with infection. 3. Pigment stone, mainly composed of calcium bilirubinate. They are usually small, multiple and black. Commonly associated with hemolytic disease. Incidence. Female sex and old age are the common risk factors. But the condition can occur in both sexes and at any age. Pathogenesis. 3 important factors implicated in pathogenesis of cholelithiasis are: 1. Metabolic. Cholesterol is soluble in bile salt and phospholipids. When bile salt is deficient or when the cholesterol level is in excess in relation to the bile salt, the bile formed is supersaturated or lithogenic. 2. Infection causes increased mucus plug formation and scarring, which form anitis for stone formation. Also many bacteria deconjugate bilirubin, which will combine with calcium to form insoluble calcium bilirubinate. 3. Stasis, important for growth of stone. Progesterone in multiparous women is believed to be contributory. Clinical presentation. Most 90 patients with gallstone diseases are asymptomatic. Symptomatic patients present with history, right upper quadrant colicky, pain, biliary colicky, dyspepsia, fatty food intolerance, flatulence, abnormal postprandial bloating. Symptoms of acute cholecystitis or other complications. Physical examination, right upper quadrant tenderness. Risk factors can be identified. Complications of gallbladder stone. 1. In the gallbladder, chronic cholecystitis. Acute cholecystitis. Gangrene. Perforation. Empyema. Mucocele. Carcinoma. 2. In the bile duct. Obstructive jaundice. Cholangitis. Acute pancreatitis. 3. In intestine. Acute intestinal obstruction, gallstone ileus. Diagnostic workup. Ultrasound detects stone in the gallbladder. Plain abdominal film, only 10 of stones are radio-opaque and visible on X-ray. Differential diagnosis. 1. Peptic ulcer disease. 2. Hiatal hernia. 3. Carcinoma of stomach. 4. Diverticular disease. 5. Angina pectoris. Treatment. Surgery, open or laparoscopic. 1. Cholecystectomy. The mainstay of treatment. 2. Cholecystostomy for bad risk patients with severe infection. severe acute cholecystitis or gallbladder empyema. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atif Ahmed.
Hello everybody, welcome to No1doctor channel. Today video is about hand problems, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about hand problems. Carpal tunnel syndrome occurs mostly in women who do repetitive hand work such as typing. They complain about numbness and tingling in their hands, particularly at night, and in the distribution of the median nerve radial 31-2 fingers. The symptoms can be reproduced by hanging the hand limply for a few minutes, or by tapping, percussing or pressing the median nerve over the carpal tunnel. Initial treatment is splints and anti-inflammatory agents. If unsuccessful, electrodiagnostic studies of nerve conduction are done to justify the need for surgery. Endoscopic release is the currently favored operation. Trigger finger also favors women. Patients wake up in the middle of the night with a finger acutely flexed, and they are unable to extend it unless they pull it with the other hand. When they do so, there is a painful snap. Steroid injection is the first line of therapy. Surgery is the treatment of last resort. De Quervain tenosynovitis is seen in young mothers who, as they carry their baby, force their hand into wrist flexion and thumb extension to hold the baby's head. They complain of pain along the radial side of the wrist and the first dorsal compartment. On physical exam, the pain can be reproduced by asking her to hold her thumb inside her closed fist, then forcing the wrist into ulnar deviation. Splint and anti-inflammatory agents can help, but steroid injection is best. Surgery is rarely needed. Dupuytren contracture occurs in older men of Norwegian ancestry. There is contracture of the palm of the hand, and palmar facial nodules can be felt. Steroids or collagenase injections can be helpful. If not, surgery may be needed when the hand can no longer be placed flat on a table. Felon is an abscess in the pulp of a fingertip, caused by a neglected penetrating injury. Patients complain of throbbing pain and have all the classic findings of an abscess, including fever. Because the pulp is a closed space with multiple facial trabecula, pressure can build up and lead to tissue necrosis. Thus surgical drainage must be urgently done. Gamekeeper thumb is an injury of the ulnar collateral ligament sustained by forced hyperextension of the thumb, historically suffered by gamekeepers when they killed rabbits by dislocating their necks with a violent blow with the extended thumb, nowadays seen as a skiing injury when the thumb gets stuck in the snow or the ski strap during a fall. On physical exam, there is collateral laxity at the thumb metacarpophalangeal joint, and if untreated it can be dysfunctional and painful, and lead to arthritis. Casting is usually done. Jersey finger is an injury to the flexor tendon sustained when the flexed finger is forcefully extended, as in someone unsuccessfully grabbing a running person by the jersey. When making a fist, the distal phalanx of the injured finger does not flex with the others. Mallet finger is the reverse of the previous one. The extended finger is forcefully flexed, a common.
Hello everybody. Welcome to No1doctor channel. Today video is about hematuria, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like, share our videos, subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about hematuria. Very common problem, may be a sign of serious underlying disease. 10% of urology referrals. Overall prevalence 5%, up to 20% in those aged over 60 years. Microscopic or macroscopic hematuria. Painful hematuria suggests infection. Pain at start of stream suggests prostatic or urethral origin. Loin pain suggests renal origin. Microscopic hematuria confirmed on 2 freshly voided urines without infection, if aged over 40 years, will need MSU urine cytology UEPSA prostate-specific antigen IV or kidneys, ureters and bladder cup X-ray and USSN flexible cystoscopy. Investigate if under 40 years if there are risk factors in history, like smoking. Consider renal referral if there is evidence of casts, dysmorphic cells, proteinuria, hypertension or an elevated creatinine. Macroscopic hematuria visible to the naked eye. All patients should be investigated MSU urine cytology UEPSA CT urogram and flexible cystoscopy. If all normal, probably prostatic in origin. However, if persistent, consider magnetic resonance imaging MRI or renal angiogram, as vascular malformations are rare causes. Novel markers for bladder cancer like NMP22. Patients may need admission for bladder washout or transfusion or general anesthetic cystoscopy and washout in severe cases. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Atif Ahmed. Best wishes.
Hello everybody. Welcome to No1doctor channel. Today video is about abdominal wall hernias, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about abdominal wall hernias. Abdominal wall hernias are common surgical problems encountered in all levels of healthcare facilities. Adequate knowledge to reach to the correct diagnosis and appropriate management plan help the care provider to prevent serious complications which could be fatal. Definitions. Hernia is a protrusion of a viscus through an opening in the wall of the cavity. Important terminologies. Hernial sac is an outpouch of the peritoneum. It has 4 parts: mouth, neck, body and fundus. Content is a viscus or any other organ inside a sac. It can be small bowel and omentum, the commonest, large bowel appendix. The bladder. Reducible hernia when the protruded viscus can be returned back to the abdomen. Irreducible hernia when the contents can't be returned back. Obstructed hernia, the content of the hernia intestine is occluded but no impairment of vascular supply. Strangulated hernia when the vascularity of protruded viscus is impaired. Richter's hernia when only one side of the wall of the intestine is herniated. Here strangulation of the bowel can occur without intestinal obstruction. Sliding hernia when an extraperitoneal structure form part of the wall of the sac. Risk factors for abdominal wall hernia development. Increased intra-abdominal pressure resulting from chronic cough, straining at urination or defecation, heavy weight lifting, abdominal distension, weakened abdominal wall, advanced age, malnutrition, congenital defect PPV, trauma or surgery. Clinical features. History. Lump which varies in size. Pain, local aching, discomfort. Factors predisposing to increased intra-abdominal pressure. Symptoms of intestinal obstruction or strangulation. Physical examination. Patient is examined in standing and lying position. Lump reducible, cough impulse with bowel sound. May be reduced when patient is lying and increases in size when patient is coughing or straining. Relation of the lump with the common references: pubic tubercle, inguinal ligament. Signs of obstruction: tense, tender, irreducible with absent cough impulse. Signs of strangulation: more tenderness, with warm indurated, and inflamed overlying skin. Investigation. Hernia is a clinical diagnosis and investigation is rarely needed. Complications of abdominal wall hernias: 1. Irreducibility. 2. Obstruction. 3. Strangulation is a surgical emergency. Risk of obstruction and strangulation is very high in femoral hernia, periumbilical hernia and indirect inguinal hernia with narrow neck. Principles of management. Spontaneous resolution is unlikely. The risks of irreducibility, obstruction and strangulation increase with time. So surgical intervention is needed in most cases. Surgical treatment for abdominal wall hernias. 1. Herniotomy, removal of the sac and closure of the neck, done only in infants and children. 2. Herniorrhaphy, herniotomy and repair of the wall to prevent recurrence. Obstruction and strangulation. This is one of the causes of intestinal obstruction, acute abdomen. Therefore, one shouldn't forget to examine the hernial sites during evaluation of the patient with intestinal obstruction. Treatment options. Non-operative treatment. Gentle reduction taxis can be indicated in obstructed hernia in infants but not advisable in adults due to the risk of mass reduction. Procedure taxis. Put patient in head down position. Sedative is given. Gentle manipulation to reduce the hernia. NB. No place for vigorous manipulation and be ready to stop the procedure when any difficulty arises. Urgent surgery is indicated in great majority of obstructed hernia and all strangulated hernia. Specific types of hernia. Anatomy of inguinal and femoral canal. Inguinal canal boundaries. Anteriorly, external oblique aponeurosis. Posteriorly, fascia transversalis. Inferiorly, inguinal ligament. Superiorly, conjoined tendon and internal oblique muscle. This canal runs in antero-inferior direction from internal to external ring. The internal ring lies 2 cm above and 2 cm medial to mid-inguinal ligament. The external ring lies just above the pubic crest and tubercle. Contents of inguinal canal. In male, spermatic vessels, vas deferens, ilioinguinal nerve, genitofemoral nerve. In female, round ligament. Anatomy of femoral canal. Is a narrow rigid space bounded by inguinal ligament, superiorly. Pectineal part of inguinal ligament posterior. Lacuna part of inguinal ligament medially, femoral vein laterally. The narrow rigid space makes this types of hernia more prone to obstruction and strangulation. Inguinal hernia. Accounts for 80% of all external abdominal wall hernia. Commonest is all ages and sexes. 20x more common is males than women. More common on right side classification. 1. Indirect type, passes through internal inguinal ring along the inguinal canal. May extend down to the scrotum. 2. Direct type, bulges through the post wall of inguinal canal. Indirect inguinal hernia 60 on right, 40 left-hand side and 20 bilateral. Due to congenital defect or potential defect which is the remnant of processus vaginalis. 20 times more common in men. Direct inguinal hernia. Due to wear and tear associated with advanced age and increased intra-abdominal pressure. Femoral hernia. Acquired downward protrusion of intestinal contents into the femoral canal. 4 times more common in females middle-aged multiparous. Rare in children. Clinical features. History. Elderly or middle-aged woman with thin body build. Lump on anterior and upper thigh. May present with complaints associated with obstruction or strangulation. Physical examination. Small lump on lower groin, lateral and below pubic tubercle. Reducible irreducibility. Bowel sound, cough, impulse usually absent. Management. Surgical repair without delay. Umbilical paraumbilical hernia. Umbilicus is one of the weak sites of the abdomen. A hernia can occur at this potential site. Risk factors. Female sex. Multiple parities. Obesity. Ascites. Complications. Obstruction. Strangulation. Rupture. Treatment. Expectant, spontaneous closure is expected in 80 cases of umbilical hernia in under 5 children. Surgery, beyond 5 years. Incisional hernia. Risk factors. Wound infection. Poor surgical technique, improper facial repair. Chronic cough or straining. Obesity. Clinical features. Risk of obstruction and strangulation is very rare. Local discomfort. Cosmetic problems. Difficulties with micturition and bowel movement when very large. Treatment. Hernioplasty. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Artef Ahmed. My best wishes.
Hello everybody. Welcome to No1doctor channel. Today video is about Horner syndrome, which is part of our playlist called Short Medical Notes. in which we will have short videos about important topic in medicine, but please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Horner syndrome is ptosis, meiosis, and anhidrosis due to dysfunction of cervical sympathetic output. Horner syndrome results when the cervical sympathetic pathway running from the hypothalamus to the eye is disrupted. The causative lesion may be primary, including congenital, or secondary to another disorder. Lesions are usually divided into the following: central EG, brainstem ischemia, syringomyelia, brain tumor, peripheral EG, pancoast tumor, cervical adenopathy, neck and skull injuries, aortic or carotid dissection, thoracic aortic aneurysm. Peripheral lesions may be preganglionic or postganglionic in origin. Symptoms of Horner syndrome include ptosis, meiosis, anhidrosis, and hyperemia of the affected side. Diagnosis of Horner syndrome: cocaine eye drop test, MRI or CT. To diagnose Cosen's-Tilling eye drops can help confirm and characterize Horner syndrome. Patients with Horner syndrome require MRI or CT of the brain, spinal cord, chest, or neck depending on clinical suspicion to localize the abnormality. Treatment of Horner syndrome. Treatment of the cause. The cause of Horner syndrome, if identified, is treated. There is no treatment for primary Horner syndrome. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef Ahmed. Hello everybody. Welcome to No1doctor channel. Today video is about Hydatid cyst of the liver, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine, but please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about Hydatid cyst of the liver. This is a parasitic disease caused by infestation with the Echinococcus granulosus. Incidence: it occurs wherever a large number of sheep are raised. Pathology: the liver is the most commonly affected organ in the body. The right lobe is affected in 85%, usually in a unilocular appearance. The hepatic hydatid cyst is usually superficial and composed of two layers: laminated wall, an inner germinative membrane, and an outer adventitia. Inside the main hydrated vesicle, daughter cysts are usually found that are pathognomonic to the disease. Clinical manifestation: usually asymptomatic. Symptom of pressure on adjacent organs, upper abdominal pain and tenderness, palpable mass or diffuse liver enlargement, weight loss, jaundice and ascites, uncommon, with secondary infection, fever, chills and tender hepatomegaly, urticaria and erythema. Complications: 1. Rupture can be into biliary tree, thoracic or peritoneal cavity. 2. Suppuration, death of the parasite and conversion into pyogenic abscess. 3. Anaphylactic shock. 4. Penetration stomach, colon, pancreas, kidney. 5. Bronchopleural and hepatobronchial fistulas. Investigations: ultrasound of the abdomen, cyst and daughter cysts. Cassoni skin test, if reagents are available. Chest X-ray to rule out concomitant lung infection or pulmonary complication. Treatment: expectant, small or dead calcified cyst. Medical: albendazole or mebendazole for 2-4 weeks for multilocular disease or patients unfit for surgery. Surgical: definitive treatment. Differential diagnosis: Amoebic liver abscess, non-parasitic liver cysts, tumor, pyogenic liver abscess. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Appendicitis.
Welcome to our YouTube channel No1doctor. Today we'll talk about impotence as a part of our short medical notes series. A common problem, increasing incidence with age. Wide variety of causes of impotence. Neurological, autonomic neuropathy usually secondary to diabetes, multiple sclerosis and spinal injuries. Vascular, pelvic or aorto-iliac disease. Iatrogenic, commonly A and B blockers, psychotropic agents. Alcohol abuse. Psychological, depression, endocrine, hyperprolactinemia, hypohyperthyroidism, Cushing's syndrome, androgen deficiency. Signs. Loss of libido is a sign of androgen deficiency and hyperprolactinemia. Spontaneous morning erections with impotence are suggestive of psychogenic disease. Treatment. Treat underlying disease if possible. Phosphodiesterase inhibitors sildenafil, vardenafil and tadalafil improve penile blood flow via nitric oxide. Testosterone treatment if there is proven hypogonadism. Thanks for watching. Please like and share. With my best wishes, Dr. Ahmed.
Hello everybody. Welcome to No1doctor channel. Today video is about leg ulcers, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about leg ulcers. Diabetic ulcers are typically indolent and located at pressure points heel, metatarsal head, tip of toes. They start because of the neuropathy, and they fail to heal because of the microvascular disease. Theoretically they can be healed with good control of the diabetes and by keeping them clean with the leg elevated for many weeks or months. In reality they often get worse and lead to amputations. Ulcers from arterial insufficiency are usually as far away from the heart as they can be, at the tip of the toes. They look dirty, with a pale base devoid of granulation tissue. The patient has other manifestations of arteriosclerotic occlusive disease: absent pulses, trophic changes, claudication or rest pain. Workup begins with Doppler studies looking for a pressure gradient. If there isn't one, there is microvascular disease not amenable to surgical therapy. Then CT angio, MRI angio or arteriograms, and surgical revascularization or angioplasty and stents. In the evaluation of chronic foot ulcers, a workup is often done for both diabetes and arteriosclerotic occlusive disease, inasmuch as both problems often coexist in the same patient. Venous stasis ulcers develop in chronically edematous, indurated, and hyperpigmented skin above the medial malleolus. The ulcer is painless, with granulating bed. The patient has varicose veins and suffers from frequent bouts of cellulitis. Duplex scan is useful in the workup. Treatment revolves around physical support to keep the veins empty, best done with support stockings measured to fit the patient. Surgery may be required. Vein stripping, grafting of the ulcer, endovascular ablation with laser or radiofrequency may also be used. Marjolin ulcer is a squamous cell carcinoma of the skin developing in a chronic leg ulcer. The classic setting is one of many years of healing and breaking down, such as seen in untreated third-degree burns that underwent spontaneous healing, or in chronic draining sinuses secondary to osteomyelitis. A dirty-looking, deeper ulcer develops at the site, with heaped-up tissue growth around the edges. Biopsy is diagnostic. Wide local excision and skin grafting are done. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef Ahmed. Hello everybody. Welcome to Number 1 Doctor channel. Today video is about the Mirizzi syndrome, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine, but please do not forget to like and share our videos and subscribe to our YouTube channel Number 1 Doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about the Mirizzi syndrome. The Mirizzi syndrome refers to common hepatic duct obstruction caused by an extrinsic compression from an impacted stone in the cystic duct or Hartmann's pouch of the gallbladder. It has been estimated to occur in 0.7 to 1.8% of all cholecystectomies. It is often not recognized preoperatively, which can lead to significant morbidity and biliary injury, particularly with laparoscopic surgery. Pathogenesis. The gallbladder consists of the fundus, body, infundibulum, and neck. The infundibulum is an area of tapering between the gallbladder body and neck, and Hartmann's pouch is a bulging of the inferior surface of the infundibulum that lies close to the neck of the gallbladder. The gallbladder is connected at its neck to the cystic duct, which empties into the common bile duct. Large gallstones can become impacted in the cystic duct or in Hartmann's pouch. These stones can produce common hepatic duct obstruction, the Mirizzi syndrome, by two mechanisms: mechanical obstruction of the hepatic duct because of the proximity of the cystic duct and the common hepatic duct, and secondary inflammation with frequent episodes of cholangitis. Classification. There are two classifications that are usually used to clarify the variants of Mirizzi syndrome and to aid in choosing the appropriate therapeutic procedure. The original classification by McSherry described two types of Mirizzi syndrome. Type I: compression of the common hepatic duct or common bile duct by a stone impacted in the cystic duct or Hartmann's pouch. Type II: erosion of the calculus from the cystic duct into the common hepatic duct or common bile duct, producing a cholecystocholidochal fistula. A more useful classification system also takes into account the presence and extent of a cholecystobiliary, cholecystohepatic, or cholecystocholidochal fistula, also known as a biliobiliary fistula, due to erosion of the interior or lateral wall of the common bile duct by impacted stones. Type I: external compression of the common hepatic duct due to a stone impacted at the neck of the gallbladder or at the cystic duct. Type II: the fistula involves less than 1/3 of the circumference of the common bile duct. Type III: involvement of between 1/3 and 2/3 of the circumference of the common bile duct. Type IV: destruction of the entire wall of the common bile duct. Diagnosis. The Mirizzi syndrome is part of the differential diagnosis of obstructive jaundice. Most patients present with the clinical triad of jaundice, fever, and right upper quadrant pain. The major laboratory findings are elevations in the serum concentrations of alkaline phosphatase and bilirubin in over 90% of patients. Among patients with gallstones, these clinical and laboratory findings are most often due to cholangitis secondary to a stone in the common bile duct, cholecystolithiasis. The diagnostic approach usually begins with ultrasonography followed by cholangiography via direct cholangiography, endoscopic retrograde cholangiopancreatography, or magnetic resonance cholangiography imaging studies. Ultrasonography and CT scanning are commonly used in patients with obstructive jaundice. Ultrasonography in this setting generally reveals gallstones and a contracted gallbladder. Features suggestive of Mirizzi syndrome include dilatation of the biliary system above the level of the gallbladder neck, the presence of a stone impacted in the gallbladder neck, an abrupt change to a normal width of the common duct below the level of the stone. These features can also be seen with endoscopic ultrasonography. CT scanning does not significantly add to sonographic findings with respect to the stone and biliary obstruction, but can be helpful in ascertaining if malignancy is present by revealing enlarged porta hepatis lymph nodes or hepatic metastases lesions. Cholangiography. Preoperative cholangiography is helpful to confirm the diagnosis and to determine whether a fistula is present. Typically, endoscopic retrograde cholangiopancreatography (ERCP) is used, but percutaneous transhepatic cholangiography (PTC) can also be an option. Magnetic resonance cholangiopancreatography (MRCP) has also been shown to be a useful imaging modality for diagnosis, but lacks the option of therapeutic intervention of ERCP or PTC. Endoscopic retrograde cholangiopancreatography (ERCP) may reveal obstruction of the common hepatic duct, an impacted stone in the neck of the gallbladder or cystic duct. Stone size. Biliobiliary fistulas by the demonstration of the passage of contrast material from the proximal dilated biliary channels into the gallbladder. Duodenal, pancreatic, or ampullary pathology. Features of malignancy. ERCP is superior to percutaneous transhepatic cholangiography (PTC) in the setting of Mirizzi's syndrome for the following reasons. The cystic duct may run parallel to the common hepatic duct and join it far below the usual meeting point. This anomaly cannot be well visualized by PTC but easily seen by ERCP. Significant obstruction of the common hepatic duct. The distal common bile duct may not be adequately visualized by PTC. Preoperative ERCP and sphincterotomy, if necessary for removal of intraductal gallstones, frequently avoid the need for intraoperative bile duct exploration. Biliary decompression by internal stenting can be performed in patients with cholangitis or elevated serum bilirubin concentrations. For those requiring surgery, ERCP can help the surgeon identify the common bile duct as surgery and may reduce the risk of operative injury to the bile duct. Treatment. Surgery is the mainstay of therapy for Mirizzi syndrome, permitting removal of the causal factors, the inflamed gallbladder and the impacted stone. If the diagnosis of Mirizzi syndrome is made preoperatively, an operative strategy that minimizes the risk of injury to the biliary tract can be carried out. ERCP, direct cholangiography, or magnetic resonance cholangiography should be performed in patients with clinical jaundice, serum bilirubin 3.0 mg DL and signs and symptoms suggestive of biliary obstruction. Intraoperative cholangiography is frequently employed to clarify the biliary anatomy at the time of surgery. A standardized surgical approach has been recommended based on the classification of the variants of Mirizzi syndrome. Type I partial or total cholecystectomy, either laparoscopic or open. Common bile duct exploration is typically not required. Type 2. Cholecystectomy plus closure of the fistula, either by suture repair with absorbable material, T-tube placement, or choledicoplasty with the remnant gallbladder. Type 3 choledicoplasty or bilioenterocanastomosis choledochoduodenostomy, cholecystiduodenostomy, or choledochojejunostomy, is required, depending on the size of the fistula. Suture of the fistula is not indicated. Type 4 bilioenterocanastomosis, typically choledochojejunostomy, is preferred because the entire wall of the common bile duct has been destroyed. The approach may vary with the type of fistula present. Both the operative mortality and postoperative morbidity increase according to the severity of the lesion. Laparoscopic surgery. Mirizzi syndrome presents a difficult challenge for laparoscopic surgery because the dense adhesions and edematous inflammatory tissue cause distortion of the normal anatomy and increase the risk for biliary injury. Thus, the use of laparoscopic surgery as the primary treatment of Mirizzi syndrome is controversial, although it has been reported for patients with type I and type 2 anatomy. A systematic review of 10 case series reported that laparoscopic cholecystectomy was successful for 73 of 124 patients, 59% with Mirizzi syndrome. In a retrospective series of 35 patients who had surgery for Mirizzi syndrome, laparoscopic surgery was attempted in 15 patients and the conversion rate to open surgery was 67%. Although laparoscopic surgery may be possible in some patients with type I anatomy, open cholecystectomy remains the standard of care for Mirizzi syndrome. If a laparoscopic approach appears feasible, a prudent policy is to begin the dissection laparoscopically and convert to an open procedure if the anatomy is unclear. Endoscopic therapy. Endoscopic treatment can be effective as a temporizing measure before surgery and can be definitive treatment for unsuitable surgical candidates. Endoscopic removal of common bile duct stones also avoids the need for common bile duct exploration at the time of surgery. However, endoscopic approaches can be technically challenging, are not always successful, and have been associated with complications. Long-term success appears to be most likely in patients with type 2 disease who do not have residual gallbladder stones. The following illustrates experience in the largest reports. One report described the experience with 14 patients with Mirizzi syndrome treated with electrohydraulic lithotripsy. 12 patients had a single stone and complete clearance was achieved with one treatment session. 2 had multiple ST1s and required an additional treatment session. Asymptomatic leakage of contrast medium from the cystic duct into the peritoneal cavity was observed in one patient after removal of a large impacted cystic duct stone. This patient recovered with conservative therapy and suffered no adverse events. In another series of 25 patients with cholangiographic evidence of Mirizzi syndrome, 12 were referred for surgery after preliminary endoscopic therapy and 13 were treated solely with endoscopy. The endoscopic approach included sphincterotomy, mechanical lithotripsy, dissolution therapy with methyl tert-butyl ether, extracorporeal shockwave lithotripsy, and common bile duct stents. Complete clearance of stones from the biliary tree was achieved in only 3 of 13 patients while 9 patients were treated with long-term stenting. 5 patients died, including 2 who died of biliary causes. Association with gallbladder cancer. The Mirizzi syndrome has been associated with a high frequency of gallbladder cancer. In one series of 1759 cholecystectomies, 18 cases of Mirizzi syndrome were identified. 28% had coincidental gallbladder carcinoma versus only 2% in the patients without Mirizzi syndrome. The patients with and without gallbladder carcinoma were comparable in age, gender, type of lesions, and the duration of jaundice. The patients with gallbladder carcinoma had a longer history of pre-existent gallbladder disease, 10.4 versus 6.8 years in those without carcinoma. The serum concentration of the tumor-associated antigen CA19-9 was elevated in 12 of the 18 patients with Mirizzi syndrome but was significantly higher in those with malignancy, peaking at 1000 unit milliliter. The authors suggested that it is prudent to obtain an intraoperative frozen section of the gallbladder in patients with Mirizzi syndrome. In another report, Mirizzi syndrome was present in 133 patients out of a total of 4,803% who underwent cholecystectomy. Of the 133 patients, 75% had gallbladder cancer compared with only 1% in those with gallstone disease without Mirizzi syndrome. Of the 7 patients, the gallbladder cancer was detected preoperatively in 1, intraoperatively in 1, and on pathologic examination of the gallbladder in the remaining 5. Although gallbladder carcinoma may be common in patients with Mirizzi syndrome, the latter disorder is unusual among patients with gallbladder carcinoma. In one series of 324 cases of gallbladder carcinoma, for example, 18 had common bile duct stones but only 3 had Mirizzi syndrome. Summary and recommendations. The Mirizzi syndrome refers to common hepatic duct obstruction caused by an extrinsic compression from an impacted stone in the cystic duct. The Mirizzi syndrome is part of the differential diagnosis of obstructive jaundice. Most patients present with the clinical triad of jaundice, fever, and right upper quadrant pain. The major laboratory findings are elevations in the serum concentrations of alkaline phosphatase and bilirubin in over 90% of patients. The diagnostic approach usually begins with ultrasonography followed by cholangiography via endoscopic retrograde cholangiopancreatography, direct percutaneous cholangiography, or magnetic resonance cholangiography. Surgery is the mainstay of therapy for Mirizzi syndrome, permitting removal of the causal factors, the inflamed gallbladder and the impacted stone. Although laparoscopic surgery may be possible in some patients with type I anatomy, open cholecystectomy remains the standard of care for Mirizzi syndrome with compression of the common duct. For patients with a fistula, or erosion into the common duct, the choice of repair depends on the extent of the damage to the common duct. Endoscopic treatment with or without electrohydraulic lithotripsy (EHL) can be effective as a temporizing measure before surgery and can be definitive treatment for poor surgical candidates. The Mirizzi syndrome has been associated with a high frequency of gallbladder cancer. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef Ahmed wishes.
Hello everybody, welcome to No1doctor channel. Today video is about obstructive jaundice, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine, but please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about obstructive jaundice. Definition: jaundice is a yellowish discoloration of the sclera, mucous membrane and skin. It becomes clinically evident when the level of serum bilirubin reaches 2.0 to 3.0 mg/dl. Classification: Medicall. This type of jaundice could be subdivided into prehepatic, when the cause is excessive destruction of RBC, hemolytic hepatic, when the cause is due to the liver problems. 2. Surgical, when the cause is obstruction of biliary trees, obstructive jaundice. Causes of extrahepatic biliary obstruction in the lumen. Gallstone the most common. Parasitic occlusion e.g. ascaris, liver flukes. Blood clot. Obstruction in the wall, atresia congenital. Stricture post-traumatic. Tumor of the bile duct. Extrinsic compression. Carcinoma of head of pancreas, the second most common. Carcinoma of ampulla of vata pancreatitis. Lymph node around porta hepatis. Colorectal cyst. Clinical manifestation. History, helpful to differentiate surgical jaundice from medical jaundice for management decision. Intermittent jaundice, if it is due to stone. Progress of jaundice progressively deepening or intermittent. Or pruritus. Urine and stool clay color change is indicative of obstruction. Right upper quadrant abdominal pain. Loss of appetite, weight loss. History of abdominal trauma, surgery. Physical examination, general appearance, obesity, emaciation. Depth of jaundice or pallor. Hepatomegaly, splenomegaly, ascites, palpable gall bladder, liver mass, skin scratch marks. Note the following distinctions of various causes of jaundice. Surgical jaundice is characterized by yellow-green icterus. Pruritus of the skin more during nighttime. Clay-colored stool due to absent bile. Dark brown urine due to conjugated bilirubin in the urine. Jaundice due to cholelithiasis is characterized by history of chronic colicky right upper quadrant pain. Intermittent jaundice. Risk factors for gall bladder stone formation or history of gall bladder stone diagnosed. Usually impalpable gall bladder. Jaundice of neoplastic cause is characterized by progressively deepening jaundice. Anorexia, weight loss, and pallor. Palpable gall bladder with mild or no pain. Courvoisier's law: if in presence of jaundice, the gall bladder is palpable, then the jaundice is unlikely to be due to stone. True in 60% of cases. Investigations. Hemoglobin, anemia suggests malignancy. Urinalysis, bilirubin or urobilinogen. Serum bilirubin, total and direct. Serum alkaline phosphatase. Ultrasound, gallstone, colorectal cyst, dilated bile duct, neoplasm. Liver function test. Prothrombin time. Treatment. Surgical. The patient should be sent to a hospital for surgery. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr.
Hello everybody. Welcome to No1doctor channel. Today video is about ophthalmology diseases, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about ophthalmology diseases. Children. Amblyopia is a vision impairment resulting from interference with the processing of images by the brain during the first 6 or 7 years of life. The most common expression of this phenomenon is the child with strabismus. Faced with 2 overlapping images, the brain suppresses one of them. If the strabismus is not corrected early on, there will be permanent cortical blindness of the suppressed eye, even though the eye is perfectly normal. Should an obstacle impede vision in one eye during those early years, for instance, a congenital cataract, the same problem will develop. Strabismus is verified by showing that the reflection from a light comes from different areas of the cornea in each eye. Strabismus should be surgically corrected when diagnosed to prevent the development of amblyopia. When reliable parents relate that a child did not have strabismus in the early years but develops it later in infancy, the problem is an exaggerated convergence caused by refraction difficulties. In that case, corrective glasses instantly resolve the problem. True strabismus does not resolve spontaneously. A white pupil in a baby leukocoria is an ophthalmologic emergency, as it may be caused by a retinoblastoma. Even if the white pupil is caused by a less lethal problem, like a congenital cataract, it should be attended to in order to prevent amblyopia. Adults' glaucoma is a very common source of blindness, but because of its silent nature, it is unlikely to be discovered by regular physicians or to be tested for in an exam. One variant, however, should be recognized by every physician who might encounter it. Acute angle closure glaucoma shows up as very severe eye pain or frontal headache, typically starting in the evening when the pupils have been dilated for several hours watching a double feature at the movies, or watching TV in a dark room. The patient, often a female of Asian extraction, may report seeing halos around lights. On physical exam, the pupil is mid-dilated and does not react to light, the cornea is cloudy with a greenish hue, and the eye feels hard as a rock. Emergency treatment is required. Ophthalmologists will drill a hole in the iris with a laser beam to provide a drainage route for the fluid that is trapped in the anterior chamber. While waiting for the ophthalmologist, administer systemic carbonic anhydrase inhibitors such as Diamox and apply topical beta blockers and alpha-2 selective adrenergic agonists. Mannitol and pilocarpine may also be used. Orbital cellulitis is another ophthalmologic emergency. The eyelids are hot, tender, red, and swollen, and the patient is febrile, but the key finding when the eyelids are pried open is that the pupil is dilated and fixed, and the eye has very limited motion. There is pus in the orbit, and emergency CT scan and drainage have to be done. Chemical burns of the eye require massive irrigation, like their counterparts elsewhere in the body. Irrigation with plain water has to be started as soon as possible wherever the injury happened. It cannot wait until arrival at the hospital. Once the eye has been pried open and washed under running water for about half an hour, transportation to the ER should be arranged. At the hospital, irrigation with saline is continued, corrosive particles are removed from hidden corners, and before the patient is sent home, pH is tested to assure that no harmful chemicals remain in the conjunctival sac. As is true elsewhere in the body, alkaline burns are worse than acid burns. Retinal detachment is another emergency that should be recognized by all physicians. The patient reports seeing flashes of light and having floaters in the eye. The number of floaters gives a rough idea of the magnitude of the problem. The individual with 1 or 2 floaters may only have vitreous tugging at the retina, with little actual detachment. The person who describes dozens of floaters, or a snowstorm within the eye, or a big dark cloud at the top of his visual field has a big horseshoe piece of the retina pulled away and is at risk of ripping out the rest. Emergency intervention, with laser spot welding, will protect the remaining retina. Embolic occlusion of the retinal artery is also an emergency, although little can be done about it. The patient, typically elderly, describes sudden loss of vision from one eye. In about 30 minutes the damage will be irreversible, but the standard recommendation is for the patient to breathe into a paper bag and have someone repeatedly press hard on the eye and release while he is in transit to the ER. The idea is to vasodilate and shake the clot into a more distal location, so that a smaller area is ischemic. Newly diagnosed diabetics need ophthalmologic evaluation if they have type 2, because they may have had it for years before diagnosis was made. Retinal damage may have already occurred, and proper treatment with the use of lasers may prevent its progression. Youngsters diagnosed with type 1 are about 20 years away from getting eye problems. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef Ahmed.
Hello everybody. Welcome to No1doctor channel. Today video is about organ transplantation, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about organ transplantation. Selection of donors has been liberalized tremendously to help alleviate the acute shortage of organs. Virtually all brain-dead patients are potential candidates, regardless of age. Donors with specific infections like hepatitis or HIV can be used for recipients who have the same disease. Even donors with metastatic cancer can donate corneas. The general rule for regular physicians is that all potential donors are referred to the harvesting teams, and they will exclude the few that cannot be used at all. Transplant rejection can happen in 3 ways: hyperacute, acute, and chronic rejection. Hyperacute rejection is a vascular thrombosis that occurs within minutes of re-establishing blood supply to the organ. It is caused by preformed antibodies. It is prevented by abomatching and lymphocytotoxic cross-match, and thus it is not seen clinically. Acute rejection occurs after the first 5 days, and usually within the first 3 months. Episodes occur even though the patient is on maintenance immunosuppression. Current maintenance protocols include tacrolimus and mycophenolate mofetil, with or without prednisone. Signs of organ dysfunction suggest acute rejection, and biopsy confirms it. In the case of the liver, technical problems are more commonly encountered than immunologic rejection. Thus the first order of business when liver function deteriorates after a transplant: rising G-glutamyltransferase (GGT), alkaline phosphatase, and bilirubin, is to rule out biliary obstruction by ultrasound and vascular thrombosis by Doppler. In the case of the heart, signs of functional deterioration occur too late to allow effective therapy, thus routine ventricular biopsies by way of the jugular, superior vena cava, and right atrium are done at set intervals. The first line of therapy for acute rejection is steroid boluses. If unsuccessful, anti-lymphocyte agents OKT3 have been used, but their high toxicity is a problem. Newer antithymocyte serum is tolerated better. Chronic rejection is seen years after the transplant, with gradual, insidious loss of organ function. It is poorly understood and irreversible. Although we have no treatment for it, patients suspected of having it have the transplant biopsied in the hope that it may be a delayed and treatable case of acute rejection. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atif Ahmed.
Hello everybody. Welcome to No1doctor channel. Today video is about common adult orthopedic injuries, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about common adult orthopedic injuries. X-rays for suspected fractures should always include two views at 90 to one another and always include the joints above and below the broken bone. If the mechanism of injury suggests it, other X-rays should be taken of the bones that are in the line of force, which might also be broken. For instance, the lumbar spine when somebody falls from a height and lands on and breaks his feet. As a general rule, broken bones that are not badly displaced or angulated or that can be satisfactorily aligned by external manipulation can be immobilized in a cast-closed reduction. Broken bones that are severely displaced or angulated or that cannot be aligned easily require surgical intervention to reduce and fix the fracture. Open reduction and internal fixation. Clavicular fractures are typically at the junction of middle and distal thirds. The traditional treatment is a figure-of-8 device that, by pulling back on both shoulders, aligns the bone. Wearing a sling is more comfortable and also works well. If a very precise outcome is desired for cosmetic reasons, open reduction and internal fixation can be done. Anterior dislocation of the shoulder is by far the most common shoulder dislocation. Patients hold the arm close to their body but rotate it outward as if they were going to shake hands. There may be numbness in a small area over the deltoid, from stretching of the axillary nerve. AP and lateral rays are diagnostic. Some patients develop recurrent dislocations with minimal trauma. Posterior shoulder dislocation is rare and occurs after massive uncoordinated muscle contractions, such as epileptic seizure or electrical burn. The arm is held in the usual protective position close to the body, internally rotated. Regular X-rays can easily miss it. Axillary views or scapular lateral views are needed. Callus fracture results from fall on an outstretched hand, often in old osteoporotic women. The deformed and painful wrist looks like a dinner fork. The main lesion is a dorsally displaced, dorsally angulated fracture of the distal radius. Treat with close reduction and long arm cast. Montagia fracture results from direct blow to the ulna, such as on a raised protective arm hit by a nightstick. There is diaphyseal fracture of the proximal ulna, with anterior dislocation of the radial head. Galeazzi fracture is the mirror image of the previous one. The distal third of the radius gets the direct blow and has the fracture, and there is dorsal dislocation of the distal radio-ulnar joint. In both of these, the broken bone often requires open reduction and internal fixation, whereas the dislocated one is typically handled with closed reduction. Fracture of the scaphoid carpal navicular affects a young adult who falls on an outstretched hand. Patient complains of wrist pain. Physical exam shows localized tenderness to palpation over the anatomic snuff box. In undisplaced fractures, X-rays are usually negative, but thumb spica cast is indicated just with the history and physical findings. X-rays will show the fracture 3 weeks later. If original X-rays show displaced and angulated fracture, open reduction and internal fixation are needed. Scaphoid fractures are notorious for a very high rate of non-union. Metacarpal neck fractures, typically the fourth or fifth, or both, happen when a closed fist hits a hard surface like a wall. The hand is swollen and tender, and X-rays are diagnostic. Treatment depends on the degree of angulation, displacement, or rotary malalignment, closed reduction and ulnar gutter splint for the mild ones, Kirschner wire or plate fixation for the bad ones. Hip fractures typically happen to the old who sustain a fall. The hip hurts, and the patient's position in the stretcher is classic. The affected leg is shortened and externally rotated. Specific treatment depends on specific location as shown by X-rays. Femoral neck fractures, particularly if displaced, compromise the very tenuous blood supply of the femoral head. Faster healing and earlier mobilization can be achieved by replacing the femoral head with a prosthesis. Intertrochanteric fractures are less likely to lead to avascular necrosis and are usually treated with open reduction and internal fixation. The unavoidable immobilization that ensues poses a very high risk for deep venous thrombosis and pulmonary emboli, thus post-op anticoagulation is recommended. Femoral shaft fractures are often treated with intramedullary rod fixation. If bilateral and comminuted, they may produce enough internal blood loss to lead to shock. External fixation may help while the patient is stabilized. If they are open, they are an orthopedic emergency, requiring or cleaning and closure within 6 hours. If multiple, they may lead to the fat embolism syndrome. Knee injuries typically produce swelling of the knee. Knee pain without swelling is unlikely to be a serious knee injury. Swelling of the knee has been described as the poor man's MRI, a reference to its clinical reliability, and to the fact that MRI is the best highly technological way to look inside the knee. Collateral ligament injuries are usually sustained in a sideways blow to the knee, a common sports injury. Medial blows disrupt the lateral ligaments, and vice versa. The knee will be swollen and show localized pain by direct palpation on the affected side. With the knee flexed 30, passive induction or adduction will produce pain on the torn ligaments and allow further displacement than the normal leg. Abduction demonstrates the medial injury's valgus stress test, whereas adduction diagnoses the lateral injury's varus stress test. Isolated injuries are treated with a hinged cast. When several ligaments are torn, surgical repair is preferred. Anterior cruciate ligament injuries are more common than posterior ones. There is severe knee swelling and pain. With the knee flexed 90, the leg can be pulled anteriorly, like a drawer being opened. Anterior drawer test. A similar finding can be elicited with the knee flexed at 20 by grasping the thigh with one hand, and pulling the leg with the other. Lockman test. Posterior cruciate ligament injuries produce the opposite findings. MRIs are diagnostic. Sedentary patients may be treated with immobilization and rehabilitation, whereas athletes require surgical reconstruction. Almost all cruciate injuries are sports-related and require surgery. Meniscal tears are difficult to diagnose clinically and on X-rays, but are beautifully shown on MRI. Patients often have protracted pain and swelling after a knee injury, and they may describe catching and locking that limit knee motion, and a click when the knee is forcefully extended. Repair is done, trying to save as much meniscus as possible. Complete meniscectomy leads to late development of degenerative arthritis. Injuries to the medial meniscus, the medial collateral, and the anterior cruciate often occur simultaneously. Tibial stress fractures are seen in young men subjected to forced marches. There is tenderness to palpation over a very specific point on the bone, but X-rays are initially normal. Treat with a cast and repeat the X-rays in 2 weeks. Non-weight-bearing crutches is another option. Leg fractures involving the tibia and fibula are often seen when a pedestrian is hit by a car. Physical exam shows angulation. X-rays are diagnostic. Casting takes care of the ones that are easily reduced. Intramedullary nailing is needed for the ones that cannot be aligned. The lower leg along with the forearm is one of the most common locations for development of the compartment syndrome. Increasing pain after a long leg cast has been applied requires immediate removal of the cast and appropriate assessment. Rupture of the Achilles tendon is seen in out-of-shape middle-aged men who subject themselves to severe strain. Tennis, for instance. As they plant the foot and change direction, a loud popping noise is heard like a rifle shot, and they fall clutching the ankle. Limited plantar flexion is still possible, but pain, swelling, and limping bring them to the doctor. Palpation of the tendon reveals a gap. Casting in equinus position allows healing in several months. Surgery achieves quicker cure. Fractures of the ankle occur when falling on an inverted or verted foot. In neither case, both malleoli break. AP, lateral, and mortise X-rays are diagnostic. Open reduction and internal fixation is needed if the fragments are displaced. Orthopedic emergencies. The compartment syndrome occurs most frequently in the forearm or lower leg. Precipitating events include prolonged ischemia followed by reperfusion, crushing injuries, or other types of trauma. In the lower leg, by far the most common cause is a fracture with closed reduction. The patient has pain and limited use of the extremity. The compartment feels very tight and tender to palpation. The most reliable physical finding is excruciating pain with passive extension. Pulses may be normal. Emergency fasciotomy is required for treatment. Pain under a cast is always handled by removing the cast and examining the limb. Open fractures, the broken bone sticking out through a wound, require cleaning in the or and suitable reduction within 6 hours from the time of the injury. Posterior dislocation of the hip occurs when the femur is driven backward, such as in a head-on car collision where the knees hit the dashboard. The patient has hip pain and lies in the stretcher with the leg shortened, adducted, and internally rotated, and a broken hip. The leg is also shortened, but it is externally rotated. Because of the tenuous blood supply of the femoral head, emergency reduction is needed to avoid avascular necrosis. Gas gangrene occurs with deep, penetrating, dirty wound stepping on a rusty nail, with lots of mud or manure. In about 3 days the patient is extremely sick, looking toxic and moribund. The affected site is tender, swollen, discolored, and has gas crepitation. Treatment includes penicillin and clindamycin, extensive emergency surgical debridement, and hyperbaric oxygen. Other galloping soft tissue infections are seen primarily in immunocompromised patients, diabetics, AIDS patients, the most common being synergistic bacterial gangrene and necrotizing fasciitis. Patients debilitated by extensive burns or widespread trauma may suffer fulminating fungal infections. The most feared of these is mucormycosis, in which the affected area is turned black. Diagnosis is confirmed by tissue biopsy. All of these conditions require repeated, massive surgical excisions of dead tissue in addition to appropriate antibiotics. Broad spectrum for synergistic bacterial gangrene and necrotizing fasciitis, 4-amphotericin B for mucormycosis. Associated neurovascular injuries. The radial nerve can be injured in oblique fractures of the middle to distal thirds of the humerus. If the patient comes in unable to dorsiflex, extend the wrist and regains function when the fracture is reduced and the arm is placed on a hanging cast or coaptation sling, no surgical exploration is needed. However, if nerve paralysis develops or remains after reduction, the nerve is entrapped and surgery has to be done. Popliteal artery injuries can occur and posterior dislocations of the knee. Attention to the integrity of pulses, Doppler studies, or CT angio, are key issues. Prompt reduction will minimize vascular compromise. Delayed restoration of flow requires prophylactic fasciotomy. Injury patterns. The second, hidden fracture. The direction of force that produces an obvious injury may produce another one that is less obvious and needs to be sought. Falls from a high landing on the feet may have obvious foot or leg fractures. Fractures of the lumbar or thoracic spine may be less obvious, and must be looked for. Head-on automobile collisions may produce obvious injuries in the face, head, and torso, but if the knees hit the dashboard, the femoral heads may be driven backward into the pelvis or out of the acetabulum. Facial fractures and closed head injuries should always prompt evaluation of the cervical spine. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atif Ahmed. Best wishes, Dr. Atif Ahmed. Best wishes. Hello everybody. Welcome to No1doctor channel. Today video is about pain syndromes, which is part of our playlist called Short Medical Notes. in which we will have short videos about important topic in medicine, but please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about pain syndromes. Trigeminal neuralgic douleur produces extremely severe, sharp-shooting pain like a bolt of lightning in the face, brought about by touching a specific area and lasting about 60 seconds. Patients are in their 60s and have a completely normal neurologic exam. The only finding on physical may be an unshaven area in the face, the trigger zone, which the patient avoids touching. MRI is done to rule out organic lesions. Treatment with anticonvulsants is often successful, notably carbamazepine. If not, radiofrequency ablation can be done. Some surgeons believe pounding from a nearby vessel may be responsible, and they advocate an operation to separate them. Reflex sympathetic dystrophic algia develops several months after a crushing injury. There is constant, burning, agonizing pain that does not respond to the usual analgesics. The pain is aggravated by the slightest stimulation of the area. The extremity is cold, cyanotic, and moist. A successful sympathetic block is diagnostic, and surgical sympathectomy is curative. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef Ahmed.
Hello everybody. Welcome to No1doctor channel. Today video is about pediatric surgery, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine, but please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about pediatric surgery. Birth through the first 24 hours. Most congenital anomalies require surgical correction, but in many of them other anomalies have to be looked for first. In some cases clusters are seen. Esophageal atresia shows up with excessive salivation noted shortly after birth, or choking spells when first feeding is attempted. A small NG tube is passed, and it will be seen coiled in the upper chest when X-rays are done. If there is normal gas pattern in the bowel, the baby has the most common form of the four types, in which there is a blind pouch in the upper esophagus and a fistula between the lower esophagus and the tracheobronchial tree. Before therapy is undertaken, associated anomalies, the vertebral, anal, cardiac, tracheal, esophageal, renal, and radial vector constellation have to be ruled out. Look at the anus for imperforation, check the X-ray for vertebral and radial anomalies, do echocardiogram looking for cardiac anomalies, and sonogram looking for renal anomalies. Primary surgical repair is preferred, but if it has to be delayed, a gastrostomy has to be done to protect the lungs from acid reflux. Imperforate anus may be the clinical presentation noted on physical exam for the vector collection of anomalies. If so, the others have to be ruled out as detailed above. For the imperforate anus itself, look for a fistula nearby to vagina or perineum. If present, repair can be delayed until further growth but before toilet training time. If not, a colostomy needs to be done for high rectal pouches and later the repair, or a primary repair can be done right away if the blind pouch is almost at the anus. The level of the pouch is determined with X-rays taken upside down so that the gas in the pouch goes up, with a metal marker taped to the anus. Congenital diaphragmatic hernia is always on the left, and the bowel will be up in the chest. The real problem is not the mechanical one, but the hypoplastic lung that still has fetal-type circulation. Repair must be delayed 3 or 4 days to allow maturation. Babies are in respiratory distress and need endotracheal intubation, low-pressure ventilation, careful not to blow up the other lung, sedation, and NG suction. Prenatal sonogram is diagnostic. Very severe cases that do not respond to conventional therapy are treated with extracorporeal membrane oxygenation (ECMO). The patients in these cases are children who would otherwise die, a circumstance that justifies this very expensive procedure. But ECMO is not a panacea in this setting. Early mortality from neurological complications, including intracranial bleeding, is very high, and the long-term health of the survivors is uncertain. Some have experienced continued pulmonary function deterioration and severe developmental problems. Gastroschisis and omphalocele show up with an abdominal wall defect in the middle of the belly. In gastroschisis the cord is normal, it reaches the baby, the defect is to the right of the cord, there is no protective membrane, and the bowel looks angry and matted. In omphalocele the cord goes to the defect, which has a thin membrane under which one can see normal-looking bowel and a little slice of liver. Small defects can be closed primarily, but large ones require construction of a celastic silo to house and protect the bowel. The contents of the silo are then squeezed into the belly, a little bit every day, until complete closure can be done in about a week. Babies with gastroschisis also need vascular access for parenteral nutrition, because the angry-looking bowel will not work for about 1 month. Exstrophy of the urinary bladder is also an abdominal wall defect, but over the pubis, which is not fused, with a medallion of red bladder mucosa, wet and shining with urine. The baby has to be transferred immediately to a specialized center where a repair can be done within the first 1 or 2 days of life. Delayed repairs do not work. Green vomiting in the newborn has ominous significance. Green vomiting and a double bubble picture in X-rays, a large air fluid level in the stomach, and a smaller one to its right in the first portion of the duodenum are found in duodenal atresia, annular pancreas, or malrotation. All of these anomalies require surgical correction, but malrotation is the most dangerous because the bowel can twist on itself, cut off its blood supply, and die. If in addition to the double bubble there is a little normal gas pattern beyond, the chances of malrotation are higher. Malrotation is diagnosed with contrast enema safe, but not always diagnostic or upper GI study more reliable, but more risky. Although described here as a problem of the newborn, the first signs of malrotation can show up at any time within the first few weeks of life. Intestinal atresia also shows up with green vomiting, but instead of a double bubble there are multiple air fluid levels throughout the abdomen. There may be more than one atretic area, but no other congenital anomalies have to be suspected because this condition results from a vascular accident in utero. A few days old through the first 2 months of life. Necrotizing enterocolitis is seen in premature infants when they are first fed. There is feeding intolerance, abdominal distension, and a rapidly dropping platelet count in babies, a sign of sepsis. Treatment: stop all feedings and administer broad-spectrum antibiotics, for fluids, and for nutrition. Surgical intervention is required if the infant develops abdominal wall erythema, air in the portal vein, intestinal pneumatosis, presence of gas in the bowel wall, or pneumoperitoneum, signs of intestinal necrosis and perforation. Meconium ileus is seen in babies who have cystic fibrosis, often hinted at by the mother having it. They develop feeding intolerance and bilious vomiting. X-rays show multiple dilated loops of small bowel and a ground glass appearance in the lower abdomen. Gastric enema is both diagnostic microcolon and inspissated pellets of meconium in the terminal ileum, and therapeutic gastric draws fluid in, dissolves the pellets. Hypertrophic pyloric stenosis shows up at age 3 weeks, more commonly in firstborn boys, with non-bilious projectile vomiting after each feeding. The baby is hungry and eager to eat again after he vomits. By the time they are seen they are dehydrated, with visible gastric peristaltic waves and a palpable olive-size mass in the right upper quadrant. If the mass cannot be felt, a sonogram is diagnostic. Therapy begins with rehydration and correction of the hypochloremic, hypokalemic metabolic alkalosis, followed by Ramstedt pyloneotomy or balloon dilatation. Biliary atresia should be suspected in 6 to 8 week-old babies who have persistent, progressively increasing jaundice, which includes a substantial conjugated fraction. Do serologies and sweat test to rule out other problems, and do Hida scan after 1 week of phenobarbital, which is a powerful choleretic. If no bile reaches the duodenum even with phenobarbital stimulation, surgical exploration is needed. About 1/3 can get a long-lasting surgical derivation, about 1/3 need a liver transplant after they survived for a while with a surgical derivation, and about 1/3 need the transplant right away. Hirschsprung disease, a ganglionic megacolon, can be recognized in early life or may go undiagnosed for many years. The cardinal symptom is chronic constipation. With short segments, rectal exant may lead to explosive expulsion of stool and flatus, with relief of abdominal distension. In older kids in whom differential diagnosis with psychogenic problems is an issue, presence of fecal soiling suggests the latter. X-rays show distended proximal colon, the normal one, and normal-looking distal colon, which is the aganglionic part. Diagnosis is made with full-thickness biopsy of rectal mucosa. Ingenious operations have been devised to preserve the unique sensory input of the motor-impaired rectum, while adding the normal propulsive capability of the innervated colon. Later in infancy, intussusception is seen in 6 to 12-month-old chubby, healthy-looking kids who have episodes of colicky abdominal pain that makes them double up and squat. The pain lasts for about 1 minute, and the kid looks perfectly happy and normal until he gets another colic. Physical exam shows a vague mass on the right side of the abdomen, an empty right lower quadrant, and current jelly stools. Barium or air enema is both diagnostic and therapeutic. If reduction is not achieved radiologically or if there are recurrences, surgery is done. Child abuse should always be suspected when injuries cannot be properly accounted for. Some classic presentations include subdural hematoma plus retinal hemorrhages, shaken baby syndrome, multiple fractures in different bones at different stages of healing, and all scalding burns, particularly burns of both buttocks. The child was held by arms and legs and dipped into boiling water. Meckel diverticulum should be suspected in lower GI bleeding in the pediatric age group. Do radioisotope scan technetium looking for gastric mucosa in the lower abdomen. Undescended testicle that has not reached the scrotum by the age of 1 needs to be surgically brought down there and fixed in place or chiopexy. Note that a testicle that is in the canal at birth, but can be easily pulled down where it belongs, is not an undescended testicle, it is an overactive cremasteric muscle. Parents need to be reassured of the benign nature of the latter. Abdominal masses in children are typically discovered by the mother. Mothers constantly handle their babies, are very familiar with their anatomy, and immediately recognize a change. If, on examination, the mass moves up and down with respiration, it is most likely a malignant liver tumor, hepatoblastoma, or hepatocellular carcinoma. Alpha-fetoprotein is likely to be elevated. If the mass is deeper and non-mobile, there is an even chance that it is a Wilms tumor arising from the kidney or a neuroblastoma growing in the adrenal gland. Modern imaging devices, CT scan, MRI, can easily clarify what it is. Most of these malignancies are treated with surgical resection, if possible, and often they are subjected to additional chemotherapy or radiation. The prognosis in neuroblastoma depends on the child's age when it is discovered. The younger the patient is, the better the cure rate. A curious added feature of the neuroblastoma is that it may involute and spontaneously revert to a benign neuroma. Childhood leukemia may be cured in the near future, if current trials with genetically modified immune cells CAR T-cell therapy are successful. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Atef Ahmed. Best wishes. Dr. Artefarmed wishes.
Hello everybody. Welcome to Number 1 Doctor channel. Today video is about peptic ulcer disease, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine, but please do not forget to like and share our videos and subscribe to our YouTube channel Number 1 Doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about peptic ulcer disease, anatomy and physiology of the stomach and duodenum. The stomach is an asymmetric dilation of the proximal gastrointestinal tract. The adult capacity is 1.5 to 2.0 liters. Anatomically, it is divided into the following parts: cardia, fundus, body, anteroom, and pylorus. The pyloric sphincter regulates gastric emptying and prevents reflux of duodenal content. The wall of the stomach has four layers: mucosa, submucosa, muscularis and serosa. The stomach performs two interrelated functions in the initial phase of digestion: A. Food breakdown to form chyme through mechanical digestion and acid and pepsin action. B. Reservoir through receptive relaxation, i.e. the stomach increases its size as the amount of food in it increases. Phases of gastric secretion. There are three phases of gastric secretion: cephalic, mediated by acetylcholine secreted by the vagus nerve; gastric, mediated by the hormone gastrin by G cells; intestinal, mainly inhibitory through peptides like secretin. Pathogenesis. The pathogenesis of peptic ulcer is an imbalance in the aggressive activity of acid and pepsin and the defensive mechanisms that resist mucosal digestion. Factors contributing to the pathogenesis of peptic ulcer include: 1. Helicobacter pylori. 2. Nonsteroidal anti-inflammatory drugs, aspirin. 3. Acid hypersecretion, for example Zollinger-Ellison syndrome. 4. Rapid gastric emptying. 5. Impaired duodenal acid disposal. 6. Impaired gastric mucosal defense. 7. Duodenogastric reflux. The most convincing evidence for H. pylori infection as a cause is that eradication of H. pylori infection is associated with a near elimination of recurrence of peptic ulcer following treatment. However, only a minority 10 over a lifetime of people harboring H. pylori develop ulcers. Classification. Acid peptic disease of the stomach and duodenum includes erosive gastritis, inflammation confined to the mucosa of the stomach. Acute gastritis occur after major trauma, shock, sepsis, head injury and ingestion of aspirin and alcohol. It is generally classified as stress erosion. Chronic gastritis peptic ulcers extend through the mucosa into the submucosa and muscularis. Chronic gastric and duodenal ulcers are distinguished by the presence of an established inflammatory reaction. Duodenal ulcer usually occurs in the proximal duodenum within 1 to 2 cm of the pylorus, the portion of intestine first exposed to gastric secretion. In duodenal ulcer there is acid hypersecretion, while in gastric ulcer acid secretion is either normal or decreased. Clinical manifestation. The clinical presentation is nonspecific and the following features may not always be found. On examination it is not unusual to find localized deep tenderness in the right hypochondrium. Investigations. A. Gastroduodenoscopy and biopsy. B. Barium meal. C. Blood studies. Dropping hemoglobin shows chronic blood loss. D. H. pylori test. Treatment. Medical treatment. Acid reduction. H2 receptor antagonists, cimetidine 800 mg night for 6 weeks. Proton pump inhibitor omeprazole 20 mg. D. Irritants should be avoided. Anti-H. pylori treatment is given in the following manner if positive for H. pylori test: bismuth tablets, amoxicillin for 2-4 weeks, metronidazole. Relapses are treated with the standard treatment in cases of duodenal ulcer. However, gastric ulcers need endoscopic evaluation and biopsy to rule out malignancy. Surgical treatment. The patient is referred for surgery in the following conditions: A. Complications: obstruction, perforation or bleeding. B. Intractability, failure of medical treatment. Complications. Overall, in men, there is a 5% risk of perforation. About 10% of patients will have significant bleeding. Perforated peptic ulcer. Sex ratio 2 to 1, age 45-55 years, anterior surface of duodenum location. Past history of PUD is common. Gastric contents spill over the peritoneum and bring about peritonism, which will be followed by bacterial peritonitis after 6 hours. Clinical features: sudden onset of abdominal pain, pale, anxious, raised pulse rate, abdomen still, not moving with respiration tender, board-like rigidity, liver dullness may be absent. After 6 hours, peritonitis issue with silent abdominal distension and patient progressively deteriorates to death. If the perforation occurs slowly, the presentation may be less dramatic. Erect plain abdominal X-ray, preferably a chest X-ray, may show air under the diaphragm. Treatment: patient is resuscitated. Antibiotic therapy, continuous gastric aspiration and breathing exercise are also important. Urgent laparotomy done to do peritoneal toilet and closure of perforation with a mental patch. Anti-H. pylori treatment started to avoid recurrence. Definitive surgical treatment if symptoms persist. Bleeding peptic ulcer. Slight bleeding frequently occurs following trauma from solid food. Severe hemorrhage is due to erosion of an artery at the base of the ulcer located posteriorly. Gastroduodenal, splenic. Patient presents with hematemesis and or melena. Management: conservative. For fluid resuscitation. Blood transfusion if indicated. Nasogastric tube insertion and saline lavage. H2 receptor antagonist. Endoscopic evaluation. Serial hematocrit determination. The patient should be referred for possible operation. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Artef Ahmed. My best wishes. Hello everybody. Welcome to No1doctor channel. Today video is about peritonitis, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about peritonitis. Definition: peritonitis is an inflammation of the peritoneum. It is an acute life-threatening condition caused by bacterial or chemical contamination of the peritoneal cavity. The major causes of peritonitis include perforated appendix, perforated peptic ulcer disease, anastomotic leak following surgery, strangulated bowel, pancreatitis, cholecystitis, intra-abdominal abscess, hematogenous spread of infective agents such as typhoid or tuberculosis, typhoid perforation, ascending infection, for example salpingitis. Classification: primary peritonitis, caused by bacterial spread via the bloodstream. Secondary peritonitis, caused during perforation or rupture of abdominal organ allowing access of bacteria and irritant digestive juices to the peritoneum. Acute peritonitis, rapid onset or brief duration with several symptoms. Chronic peritonitis, long duration since the onset involving very slow changes. Localized peritonitis, peritonitis confined to a limited space, for example pelvis. Generalized peritonitis, the whole peritoneal cavity involved. Routes of bacterial invasion: 1. Direct, contamination via perforation, a penetrating wound or during surgery. 2. Local extension, contamination by migration from an infected organ, for example through gut wall, via the fallopian tubes. 3. Bloodstream, via the blood as consequence of general septicemia. Bacteria or other pathogenic agents can gain access to the peritoneum through the mentioned routes. The infection can remain limited to a local area of the peritoneum or become generalized. Factors which favor localization of the infection include anatomical factors, for example subphrenic spaces, pathological factors, for example adhesions, surgical factors, for example drains. Etiology: the commonest bacterial invaders in peritonitis are Escherichia coli, Streptococci, bacteroids. Clinical features: commonest manifestations. Presentation of peritonitis are Sharp pain which is worse on movement, fever and tachycardia, abdominal distension, tenderness and guarding, diminished or absent bowel sounds, shoulder pain due to referred pain from diaphragmatic irritation, tenderness on rectal examination, pelvic peritonitis, abdominal distension and vomiting. Diagnosis. The diagnosis of acute peritonitis is mainly made by the clinical findings, suggestive history and physical examination. Baseline laboratory investigations like WBC count may be indicative. Plain film of the abdomen can also be diagnostic with findings related to underlying pathology, for example air under the diaphragm in perforated viscous. Ultrasound is also useful to detect abscess collection. Management. The management of patients with peritonitis should be started immediately. It includes various aspects of approaching the patient. Attention should be given to the following conditions: resuscitation, general patient care with intravenous fluids, analgesia, nasogastric tube insertion NGT, triple antibiotics ampicillin, gentamicin and metronidazole or chloramphenicol, monitoring input and output by catheterization. Surgery to control source of infection and do drainage and peritoneal lavage, supportive treatment and close follow-up. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atif Ahmed.
Hello everybody. No1doctor channel. Today video is about preoperative assessment, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about preoperative assessment. Cardiac risk. Ejection fraction under 35 normal is 55 poses prohibitive cardiac risk for non-cardiac operations. Incidence of perioperative MI is very high, and mortality for such an event is between 55 and 90. Goldman's Index of Cardiac Risk, which dates from 1977, is no longer the preferred method of assessing cardiac risk. Functional status, based on the ability to cope with life's demands, is more commonly used now. But Goldman's remains useful for listing all the findings that predict trouble. They are in descending order of importance: jugular venous distension, recent myocardial infarction, premature ventricular contractions or any rhythm other than sinus, age over 70, emergency surgery, aortic valvular stenosis, poor medical condition, and surgery within the chest or abdomen. The examination will give particular attention to the high-risk situations that intervention can improve. Jugular venous distension, which indicates the presence of congestive heart failure, is the worst single finding predicting high cardiac risk. If at all possible, treatment with ACE inhibitors, beta blockers, digitalis, and diuretics should precede surgery. Recent transmural or subendocardial MI is the next worst predictor of cardiac complications. Operative mortality within 3 months of the infarct is 40, but it drops to 6 after 6 months. Thus deferring surgery until then is the best course of action. If surgery is imperative sooner, admission to the intensive care unit ICU the day before is recommended to optimize cardiac variables. Pulmonary risk. Smoking is by far the most common cause of increased pulmonary risk, and the problem is compromised ventilation, high PCO2, low forced expiratory volume in 1 second FEV1, rather than compromised oxygenation. The smoking history, or the presence of chronic obstructive pulmonary disease (COPD) should lead to evaluation. Start with FEV1, and if it is abnormal, follow with blood gases. Cessation of smoking for 8 weeks and intensive respiratory therapy, physical therapy, expectorants, incentive spirometry, humidified air should precede surgery. Hepatic risk. 2 clinical findings and 3 laboratory values are used to predict operative mortality in patients with liver disease, encephalopathy, ascites, serum albumin, prothrombin time INR, and bilirubin only as it reflects hepatocyte function. The presence and severity of these factors can be combined in a variety of ways. The current favorite system is child class, in which Class A has 10 mortality, Class B 30, and Class C 80. But specific numbers are misleading, because so many other factors influence the outcome. Suffice it to say that a patient in coma with huge ascites, albumin below 2, INR twice normal, and bilirubin above 4 could not survive a haircut, much less an operation. Nutritional risk. Severe nutritional depletion is identified by loss of 20 of body weight over a couple of months, serum albumin below 3, anergy to skin antigens, or serum transferrin level of less than 200 mg/dl or a combination of the above. Operative risk is multiplied manyfold in those circumstances. Surprisingly, as few as 4 or 5 days of preoperative nutritional support, preferably via the gut, can make a big difference, and 7-10 days would be optimal if the surgery can be deferred that long. Metabolic risk. Diabetic coma is an absolute contraindication to surgery. Rehydration, return of urinary output, and at least partial correction of the acidosis and hyperglycemia have to be achieved before surgery. If the indication for surgery is a septic process, complete correction of all variables will be impossible as long as the septic process is present. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes.
Hello everybody. Welcome to No1doctor channel. Today video is about sigmoid volvulus, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about sigmoid volvulus. The sigmoid colon is the most frequent site of volvulus in the large bowel. The following are believed to be the predisposing factors: a long redundant sigmoid with a narrow pedicle of the mesocolon, high-fiber diet, chronic constipation in the elderly and among chronic mental patients. Pathophysiology. The sigmoid is grossly redundant and twists on its base in a clockwise direction. The mesocolic veins then become occluded and the arterial inflow into the twisted loop perpetuates the volvulus until it becomes irreversible. The twisted loop distends grossly and passes up under the right side of the diaphragm. Unless the situation is relieved, perforation may occur due to either pressure necrosis at the base of the twist or to a vascular necrosis at the apex. Diagnosis: clinical, abdominal cramp and distension, constipation early and vomiting late, empty rectum on digital rectal examination. Radiologic findings: 2 long fluid levels in the lower quadrant. Inverted U-shape of the sigmoid lumen, coffee bean appearance or the omega sign. Management: conservative. The uncomplicated, simple volvulus without signs of peritonitis can be deflated with a well-greased large-bore rectal tube under the guide of a sigmoidoscope if available. If the deflation fails, laparotomy and derotation of the loop has to be done, followed by elective resection to prevent recurrent attacks. Intravenous fluid should be given to rehydrate the patient if there is a sign of dehydration. Emergency surgery. In case of complicated volvulus with signs of peritonitis, the patient has to be prepared following resuscitative measures and giving antibiotics. Resection of the gangrenous segment with Hartmann's colostomy is done, which has to be closed at a later stage. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr.
Hello everybody. Welcome to No1doctor channel. Today video is about skin surgery, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about skin surgery. Exposure to the sun is the main cause of skin cancers. The typical victim is a fair-skinned person who does not enjoy the protection afforded by melanin. The damage is cumulative. A patient who repeatedly had sunburns with blistering as a youngster is very likely to develop cancers in later years. Basal cell carcinoma accounts for about 50 of these. 3 features are typical. It favors the upper part of the face, it has a timetable measured in years, and it does not metastasize. It kills by relentless local invasion rodent ulcer. It may look like a waxy, raised lesion, or it may be an ulcer. The former can be simply excised, for both diagnosis and treatment. The latter should be biopsied at the edge. Resection requires only a 1 mm margin all around. To assure cure and avoid unnecessary mutilation, a sophisticated method called Mohs surgery performs repeated microscopic sections as the excision is being done. Squamous cell carcinoma represents 25 of skin cancers and prefers the lower lip and the rest of the body. It has a timetable measured in months, and it can metastasize to lymph nodes. The latter may need to be sampled and, if involved, removed. Surgical margins for the primary lesion should be 0.52 cm. Radiation therapy is another treatment option. Melanoma is the most lethal of these tumors. Incidence is currently increasing from a long-quoted figure of 15 of skin cancers. It usually originates in a previously benign pigmented lesion. The mnemonic to recognize melanomas is A B C D E. They are asymmetrical A, with irregular borders B, different colors within the lesion C, and a diameter exceeding 0.5 cm D, or they have evolved D, i.e., an existing pigmented lesion has undergone a sudden change in its usual appearance. The prognosis and management of melanoma is determined by its depth of invasion. The details keep changing, but the basic idea is simple: superficial lesions have good prognosis, deep ones do not. Melanomas less than 1 mm deep require only local excision. Deeper lesions require wide margins 2 cm and attention to lymph nodes biopsy and/or remove as needed, and those between 1 and 4 mm benefit the most from aggressive efforts. Lesions beyond 4 mm have a terrible prognosis regardless of therapy. Metastatic malignant melanoma is a bizarre, unpredictable, and fascinating disease. It goes to the usual places: lymph nodes, liver, lung, brain, and bone, but it also is the all-time champion for metastasizing to weird places. Furthermore, it has no predictable timetable. Some patients are full of metastases and dead within a few months of diagnosis and treatment. Others go 20 years or more between the original treatment and the sudden explosion of metastases. Disseminated melanoma cannot be cured. Interferon offers a modest improvement in survival time, and thus has been the standard treatment. We now favor targeted therapy, which may be better. The tumor genes are studied and the best agent chosen. These include chemotherapy dacarbazine and immunotherapy pembrolizumab. The latter is credited with dramatic improvement for former President Jimmy Carter, whose brain mets from melanoma melted away. No one claims that he was cured, though. In their own advertising, the manufacturers of pembrolizumab promise only a chance to live longer. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Atef Ahmed. Best wishes.
Hello everybody. Welcome to No1doctor channel. Today video is about the testis, which is part of our playlist called Short Medical Notes. in which we will have short videos about important topic in medicine, but please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about the testis. Incomplete descent. This is a condition in which the testis is arrested in some part of its path to the scrotum. Ectopic testis is abnormally placed outside its path, for example perineum. The testis located out of the scrotum is usually atrophic, grossly immature. If not treated early, irreversible destruction will occur. Clinical features. Right side in 50 of the cases. Left 30. Bilateral in 20. The position of the undescended testis is intra-abdominal or inguinal canal or in the superficial inguinal pouch. Hazards. The risks of incomplete descent of the testes include sterility in bilateral cases, pain due to trauma, associated inguinal hernia, torsion, epididymoorchitis, atrophy, increased liability to malignant diseases. Treatment, orchidopexy, testicular torsion. Torsion of the spermatic cord may cause ischemia and necrosis of the testis. Predisposing conditions. Inversion of the testis, rotated testes, upside down, or transversely. High investment of the tunica vaginalis, clapper bell deformity. Separation of epididymis from the body of testis. Clinical features. Most common between 10–25 years of age. It presents with sudden agonizing pain in the groin and the lower abdomen. Vomiting is also common. Treatment. Emergency exploration is mandatory. Orchidectomy if necrotic testis is found, orchidopexy if viable. Orchiopexy is advised on the unaffected side. Hydrocele. Hydrocele is an abnormal collection of serous fluid in the tunica. Types include primary, secondary. Etiology, excessive production and defective absorption. Treatment, hydrocelectomy. Malignant tumors of the testis. 1/2 of all malignant tumors are testicular carcinoma. Malignant tumors of the testis are common in young male adults. Maldescent predisposes to malignancy. Classification. Tumors are classified based on histologic predominant cells. Seminoma 40. Teratoma 32. Combined seminoma and teratoma 14. Lymphoma 7. Other 7. Seminoma. Occurs in age range between 35–45 years. Extremely rare in children before puberty. Tumor compresses the neighboring structure as it grows. In rapidly growing tumors there may be areas of necrosis. Spread is via the lymphatics, blood-borne is rare. Teratomas. Teratomas arise from totipotent cells, contain variety of cell types. They occur in relatively younger patients compared to seminomas. Clinical features. Testicular tumors may be asymptomatic for several months except lump in the testis. Sensation of heaviness. Pain in 1/3 of the cases on examination. The testis is enlarged, smooth, firm, and heavy. Testicular sensation is lost. Secondary hydrocele in 10. Diagnosis. Blood for tumor markers such as HCG, alpha-fetoprotein. Chest X-ray. For secondary deposit treatment. Orchidectomy, removes primary tumor. Seminoma, radiotherapy after orchidectomy. Chemotherapy. Teratomas, Chemotherapy is the treatment of choice. Follow up by serum tumor markers. Prognosis: excellent. Seminoma, 95 5-year survival. Teratoma, 85 5-year survival. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atif Ahmed.
Hello everybody. Welcome to Number 1 Doctor channel. Today video is about the urethra, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel Number 1 Doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about the urethra, congenital abnormalities, meatal stenosis. This is a condition which usually follows fibrosis after circumcision and if left untreated leads to chronic retention then chronic renal failure. Clinical feature: spraying and dribbling in lesser degree of stenosis. Urinary retention. Treatment: metotomy or metaplasty, plastic reconstruction of the meatus. Congenital valves of the posterior urethra. This is a condition with presence of symmetrical valves. It can cause obstruction to the urethra of boys and is not visualized on urethroscope. Voiding urethrocystogram is diagnostic. Treatment: treatment is by initial decompression by catheterization followed by transurethral resection of the valves. Hypospadias. This is the most common congenital malformation where meatus open onto the underside of the penis, perineum or prepuce. It has associated deformity called cordifibrous cord deforms the penis. Treatment: surgical repair. Urethral injuries. There are two types: rupture of the membranous urethra, rupture of the bulbar urethra. Blow to the perineum is the mechanism of injury. Clinical features: retention of urine, perineal hematoma, bleeding from the external meatus. Treatment: no attempts to catheterize should be made before urethroscopy or urethroplasty. Suprapubic catheter insertion then surgery. Urethroplasty after 3 months. Rupture of the membranous urethra, most commonly due to pelvic fracture or can also be due to penetrating injuries. Road traffic accidents, severe crush injuries and falls all can cause this injury. Pain, bruising and dullness to percussion above the umbilicus. Treatment: initial suprapubic catheter can be put to relieve urinary obstruction followed by urethroplasty. Complication: urethral stricture, urinary incontinence. Urethral stricture. Causes: traumatic road traffic accident, falls, penetrating injuries. Inflammatory gonococcus, Mycobacterium tuberculosis. Iatrogenic catheterization, instrumentation. Clinical features: bladder outlet obstruction, younger age than the prostate patients. Diagnosis: urethroscopy, urethroplasty. Treatment: dilation with elastic or metallic boogie. Urethrotomy, internal visual incision of stricture. Urethroplasty, excision and end-to-end anastomosis, patch urethroplasty. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atif Ahmed. Hello everybody. Welcome to Number 1 Doctor channel. Today video is about urinary retention and incontinence, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about urinary retention and incontinence. Acute urinary retention is seen very commonly in men who already have significant symptoms from benign prostatic hypertrophy. It is often precipitated during a cold, by the use of antihistamines and nasal drops, and by abundant fluid intake. The patient wants to void but cannot, and the huge distended bladder is palpable. An indwelling bladder catheter needs to be placed and left in for at least 3 days. First line of long-term therapy is alpha blockers, the most selective of which is tamsulosin. 5-alpha reductase inhibitors, like finasteride or dutasteride, are used for very large glands more than 40 grams. Minimally invasive procedures using thermal ablation of prostatic tissue have not gained popularity. The traditional transurethral resection of the prostate TURP, although rarely done, remains the final surgical option for benign prostatic hypertrophy. Postoperative urinary retention is also very common, and sometimes it masquerades as incontinence. The patient may not feel the need to void because of post-op pain, medications, etc., but will report that every few minutes there is involuntary release of small amounts of urine. A huge distended bladder will be palpable, confirming that the problem is overflow incontinence from retention. Indwelling bladder catheter is needed. Stress incontinence is also very common. It is seen in middle-aged women who have had many pregnancies and vaginal deliveries. They leak small amounts of urine whenever intra-abdominal pressure suddenly increases. This includes sneezing, laughing, getting out of a chair, or lifting a heavy object. They do not have any incontinence during the night. Examination will show a weak pelvic floor, with the prolapsed bladder neck outside of the high-pressure abdominal area. Surgical repair of the pelvic floor is indicated in advanced cases with large cystocele. Pelvic floor exercises may be sufficient for early cases. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef Ahmed. Hello everybody. Welcome to No1doctor channel. Today video is about urologic tumors, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about urologic tumors. Hematuria is the most common presentation for cancers of the kidney, ureter, or bladder. Actually, most cases of hematuria are caused by benign disease, but except for the adult who has a trace of urine after significant trauma, any patient presenting with hematuria needs a workup to rule out cancer. The workup of hematuria begins with CT scan and continues with cystoscopy, which is the only reliable way to rule out cancer of the bladder. Renal cell carcinoma in its full-blown picture produces hematuria, flank pain, and a flank mass. They can also produce hypercalcemia, erythrocytosis, and elevated liver enzymes. That full-blown picture is rarely seen nowadays, when most patients are worked up as soon as they have hematuria. CT gives the best detail, showing the mass to be heterogenic solid tumor and alerting the urologist to potential growth into the renal vein and the vena cava, which could become a lethal pulmonary embolus if dislodged during the nephrectomy. Surgery is the only effective therapy. Targeted chemo is under investigation. Cancer of the bladder. Transitional cell cancer in most cases has a very close correlation with smoking, even more so than cancer of the lung, and usually presents with hematuria. Sometimes there are irritative voiding symptoms, and patients may have been treated for urinary tract infection even though cultures were negative and they were afebrile. Although cystoscopy is the best way to diagnose these, it should be preceded by CT scan. Both surgery and intravesical BCG have therapeutic roles, and a very high rate of local recurrence makes lifelong close follow-up a necessity. Prostatic cancer incidence increases with age. Most are asymptomatic and have to be sought by rectal exam. Rock-hard discrete nodule and prostatic-specific antigen PSA elevated levels for age group. Transrectal needle biopsy guided by sonogram when discovered by PSA establishes diagnosis. CT helps assess extent and choose therapy. Surgery and/or radiation are choices. Widespread bone metastases respond for a few years to androgen ablation, surgical orchiectomy or medical luteinizing hormone-releasing hormone agonists, or anti-androgens like flutamide. Testicular cancer affects young men, in whom it presents as a painless testicular mass. Because benign testicular tumors are virtually non-existent, biopsy is done with a radical orchiectomy by the inguinal route. Blood samples are taken pre-op for serum markers of fetoprotein and B-human chorionic gonadotropin beta HCG, which will be useful for follow-up. Further surgery for lymph node dissection may be done in some cases. Most testicular cancers are exquisitely radiosensitive and chemosensitive platinum-based chemotherapy, offering many options for successful treatment in advanced metastatic disease. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atif Ahmed.
Hello everybody. Welcome to Number 1 Doctor channel. Today video is about urologic emergencies, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel Number 1 Doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about urologic emergencies. Testicular torsion is seen in young adolescents. They have very severe testicular pain of sudden onset, but no fever, pyuria, or history of recent mumps. The testis is swollen, exquisitely tender, high-riding, and with a horizontal eye. The cord is not tender. This is one of the few urologic emergencies, and time wasted doing any tests is tantamount to malpractice. Immediate surgical intervention is indicated. After the testis is untwisted, an orchiopexy is done. Many urologists also fix the other side. Acute epididymitis is the condition with which testicular torsion could be confused. It happens in young men old enough to be sexually active, and it also starts with severe testicular pain of sudden onset. There is fever and pyuria, and the testis, although swollen and very tender, is in the normal position. The cord is also very tender. Lifting the scrotum helps. Acute epididymitis is treated with antibiotics, but the possibility of missing a diagnosis of testicular torsion is so dreadful that sonogram is done to rule it out. The combination of obstruction and infection of the urinary tract is the other condition besides testicular torsion that is a dire emergency. Any situation in which these two conditions coexist can lead to destruction of the kidney in a few hours, and potentially to death from sepsis. A typical scenario is a patient who is being allowed to pass a ureteral stone spontaneously and who suddenly develops chills, fever spike 104 or 105 F, and flank pain. In addition to 4 antibiotics, immediate decompression of the urinary tract above the obstruction is required. This is accomplished by the quickest and simplest means in this example, ureteral stent or percutaneous nephrostomy, deferring more elaborate instrumentations for a later, safer date. An erection lasting more than 4 hours after the use of erectile dysfunction drugs is also a dire emergency. The TV ads say so, but they gloss over the treatment. It may be necessary to stick needles into that erect penis, to draw out blood. Marketing strategy suggests it's best not to mention that. Urinary tract infection cystitis is very common in women of reproductive age, and it requires no elaborate workup. They have frequency, painful urination, with small volumes of cloudy and malodorous urine. Empiric antimicrobial therapy is used. More serious infections, like pyelonephritis,
or any urinary tract infection in children or young men requires urinary cultures and some kind of a urologic workup to rule out concomitant obstruction as the reason for the serious infection. Urologic workup uses 3 tests: sonogram, CT scan, and/or cystoscopy. The first is indicated for dilation and obstruction, the second is ideal for renal tumors, and the third is the only way to detect early bladder cancers. The old intravenous pyelogram IVP has almost disappeared, along with the nephrotoxicity and allergic reactions that made it risky. Pyelonephritis produces chills, high fever, nausea and vomiting, and flank pain. Hospitalization, 4 antibiotics guided by cultures, and urologic workup CT or sonogram are required. Acute bacterial prostatitis is seen in older men who have chills, fever, dysuria, urinary frequency, diffuse low back pain, and an exquisitely tender prostate on rectal exam. 4 antibiotics are indicated, and care should be taken not to repeat any more rectal exams. Continued prostatic massage could lead to septic shock. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atif Ahmed.
Hello everybody. Welcome to No1doctor channel. Today video is about urinary tract infection, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine, but please do not forget to like and share our videos and subscribe to our YouTube channel No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about urinary tract infection, a very common health problem usually as a result of bacterial ascent along urethra. More common in women, due to shorter urethra, moist environment and proximity to anus. Predisposing factors to urinary tract infection: sexual activity, stones, foreign bodies for example catheters, congenital abnormalities for example duplex system, horseshoe kidney, poo obstruction, bladder outflow obstruction from BPH or strictures. Other diseases including TCC or fistulae from adjacent organs. Common organisms include E. coli, Proteus spp, Pseudomonas spp, Klebsiella and Enterococcus. Symptoms: can be asymptomatic cystitis, frequency, urgency, dysuria and suprapubic pain. Fever is unusual. Pyelonephritis, loin pain, nausea, fever temp 38 degree, rigors and leukocytosis. Investigate all men. Recurrent infections, children and infections in pregnancy. Urinalysis, leukocytes and nitrites indicate infection midstream. Culture. Microscopy and culture should be used to confirm infection prior to starting antibiotics. 103 colony-forming units CFUs in uncomplicated and 105 CFUs in complicated urinary tract infectionist diagnostic. Imaging. KUB X-ray to rule out stone disease. Renal ultrasound to identify reflux and renal scarring. Consider DMS nuclear medicine scan if scarring seen. Endoscopy, cystoscopy rarely useful in young patients unless there are other risk factors, for example hematuria treatment. Conservative measures first: increase fluid intake, hygiene advice, double voiding, emptying bladder after intercourse, cranberry juice. Asymptomatic UTI, needs no treatment except in pregnancy. Uncomplicated UTI, 3-day course of antibiotics usually adequate. Recurrent infections, consider prophylactic antibiotics, rotated 3 monthly. Pyelonephritis, needs 2-week course. Exclude other causes first. Antibiotics, first-line trimethoprim or amoxicillin. High resistance rates in hospitals. Second line consider quinolone, ciprofloxacin or cephalosporin cephalexin. Obtain sensitivities before starting treatment if possible. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atif Ahmed.